Well, good noon, morning, afternoon, wherever you may be. Welcome to this meeting and webinar of the National Academy of Medicine's Value Incentives and Systems Action Collaborative. We have a very important meeting today focusing on the tools that are emerging for our ability to transform the health system, both health and healthcare, to a system which is more effective, efficient, equitable, and continuously learning. We are all sensitive to the importance of the economic factors in play in our system as a whole. The notion of how incentives are structured in the health system is especially important as we contemplate various approaches to health transformation. And that work is under the auspices of our Value Incentives and Systems Action Collaborative. I'm going to tell you a little more in a second about the organizational context within the NAM for the work of the collaborative. But first I want to introduce our two co-chairs. If we can have the next slide that shows Diane and Jim. They are Diane Holder, and this is Diane's inaugural service as co-chair of the collaborative. And welcome, Diane. Diane is president and CEO of the University of Pittsburgh Medical Center Health Plan and executive vice president of the university, and she's our newest Action Collaborative co-chair, and we're really grateful to you, Diane, for joining us in this capacity. We very much value your membership and now your co-chairmanship in this respect. And Jim Madera, who is the CEO and executive vice president of the American Medical Association. Jim is a longstanding and extremely important member of the collaborative, and the course consortium has been with us from the beginning. And indeed, it was his suggestion that we develop a little deeper dive into the area of behavioral economics, which is of such clear importance as we look to any element of the operation of our health system. It all comes down in one way or another to economics and to the incentives that shape behavior. Although those incentives are not just economic, they're regulatory incentives, there are a variety of incentives, but the importance is very clear. Essentially, incentives determine how fragmented care is or isn't, important in shaping how well clinical and population health initiatives are integrated. Incentives are key in strengthening the links between evidence, services, and outcomes. They're fundamentally important in driving interoperability of digital systems. Incentives are key to boosting institutional data sharing for continuous improvement in learning, and in recruiting individuals and families as core and continuous elements of the health team. Yet the dominant incentives in health and healthcare today instead quite clearly encourage fragmentation, opacity, inequity, and provider interests sometimes at the expense of patients and families. So today, again, with another shout out to Jim Madera, we're going to focus squarely on how to change the game. We have an extraordinarily strong agenda of participants in that respect, leading on with off with two national and international scholars and leaders in the field of behavioral economics, but then continuing on with individuals who have been at the center of the design of our health system, at the implementation of health and healthcare programs, and serving as ongoing important leaders in various elements of the system. You'll hear more about this when I turn the program over to Diane and Jim shortly. First, I'm going to run quickly through, as I indicated, a little background tour, just a level set for those who are not fully familiar with the work of the National Academy of Medicine's Leadership Consortium, some of the background. So next slide, please. The Leadership Consortium is made up of sector leaders, stakeholders from 9 different sectors in public and private independent organizations who gather collectively to work under the auspices of the National Academy of Medicine for action in their common interest, action that in various ways is intended to improve effectiveness, efficiency, equity, and continuous learning in health, medical care, and biomedical science. Next slide, please. The overarching aim of the Leadership Consortium is to foster the development of a learning health system, which is one in which science, informatics, incentives, and culture are aligned for continuous improvement, innovation, and equity, with best practices and discovery seamlessly embedded in the delivery process, individuals and families, active participants in all elements, and new knowledge generated as an integral byproduct of the delivery experience. Today, we're focused primarily on the incentives dimension, but the fact is, these are not separate, co-equally operating enterprises. They are each of them mutually reinforcing and working with the other in tandem to provide the kind of dynamics in the system which can help us move to improvements on every aspect. Next slide, please. Again, the focus is collaboration for action. The National Academies are known for good reports and convening that's important, but our focus is not only on good reports and convening key players, as in today's meeting, but in identifying action agendas that we can engage with our participating organizations for tangible progress. Next slide, please. The 4 collaboratives in our consortium are focused on those 4 dimensions that you saw in the definition of a learning health system: science, informatics, incentives, and culture. The science is engaged through our Evidence Mobilization Action Collaborative. The aim is continuous learning through real-world evidence. In the informatics, our effort is conducted through the Digital Health Action Collaborative, and the aim there is a digital infrastructure and data as a core utility. In many ways, we hope that we will see emerging a system in which data is as important a utility and as accessible a utility for improvement and learning as the utilities we rely on in our daily lives for normal operations. Incentives, the Value Incentives and Systems Action Collaborative that Diane and Jim co-chair is focused on outcomes, on payment based on health outcomes for people and populations, and our care, our Culture, Inclusion, and Equity Action Collaborative is aimed at full and equitable health engagement for people and communities. Next slide, please. Each collaborative works in effect through 4 kinds of activities: the sponsorship of organizational networks, the development of anchor principles, and the interface between the work of the principles or the principles that are established and the work of the networks, indicators of progress, and a series of collaborative projects on key issues. Next slide, please. Here is a list of some of the projects and initiatives that we have underway on value incentives and systems, the work of the VISAC. They include the Emerging Stronger Sector Assessment on the impact on our health financing system, of COVID-19 and the lessons learned in that respect. We have a series of meetings on financing that rewards better health and well-being with a coalition of philanthropic partners working with us for a longer-term initiative in that respect. And part of that work has been focused with CMMI in the past 6 months, holding a series of sessions on their responsibilities and possibilities catalyzing health system transformation. Our vital directions for health and healthcare establish priorities for 2021, and clearly a cross-cutting priority in that respect was financing and incentives. And finally, the recent report of the Health and Medicine Division on implementing high-quality primary care had a number of recommendations relevant to the health financing arena. Next slide, please. Just to elaborate briefly, the Emerging Stronger initiative is the initiative that had working groups from our leadership consortium and co-chaired by leaders on the consortium in 9 different areas. Next slide, please. Those 9 areas are identified here in terms of the release schedule for the papers that resulted and lessons learned. Those 9 areas are quality and safety, payers, patient families and communities, the latest one to come out, that was out only this week, clinicians and professional societies, public health, biomedical research, care systems, and the last 3 are coming out shortly on digital health, health product manufacturers and innovators, and with a final cross-cutting chapter, and they will all be published as a special publication. And the participants in the leadership consortium will be working with their counterparts in their various sectors to engage implementation possibilities. So that's a rapid tour of the work of the NAM Leadership Consortium. Thank you for your patience, for those of you who have heard that overview before. I'd now like to, without any further delay, but with a great deal of gratitude, turn the meeting over to Diane and Jim. And I think, Jim, you're going to lead off, is that correct?
Yes. So let me just say, well, thank you, Michael. I'm just going to touch on the intent of the meeting and some guiding questions and considerations. So as behavioral economics has taken a central role in the national conversation surrounding healthcare incentive structures, leaders are increasingly recognize the potential of this field to accelerate transformation towards effectiveness, efficiency, equity, and continuous learning. So this conversation considers how emerging lessons from this field can best be applied to foster individual as well as organizational actions that promote positive results for patients. Now, an important nuance in this conversation is recognizing that there are multiple domains within healthcare and the possibility that effective incentives may vary based on the domain. So, for example, as a former CEO of an academic medical center at University of Chicago, I can assure you that financial incentives can change institutional behavior. However, at the individual physician level, the intrinsic motivators measured in a collaborative study with RAND Health are elements such as time with patients and the ability to provide high quality care. External incentives that don't impact these intrinsic drivers may not be the effective incentive sought. And thirdly, there's the most important domain of all in healthcare, and that's our patients. And patients will also likely differentially respond to incentives, be they extrinsic, unlinked to internal motivators, or be they elements that engage those intrinsic motivators. So guiding questions of the conversation will include, how much is known about the effectiveness of various incentive strategies to promote actions that benefit health and well-being at all these various domain levels? And have best practices been established? What's the experience in aligning system-wide incentives to accelerate health transformation, and particularly after COVID-19? And then lastly, how might incentives differ in those subdomains, such as healthcare administration at the institutional level, patient level, and provider level? And in considering physicians, we need to remember that although the trend is really strong toward employment, in 2020, still 44% of all patient care physicians were still self-employed. So the domain to which an incentive is applied in healthcare is not a monolithic entity when one considers these various domains. So let me ask Diane just to give an overview of the logistics and agenda.
Thanks, Jim. I'm very pleased to be here today and to participate as a co-chair of this very, I think, important collaborative. You know, the pandemic's taught us many things, including underscoring that human behavior is complex and that we don't always act as some would describe logically or as economic self-interest would predict. But during this period, health disparities have become increasingly visible to the general public as well as regulators and I think the health industry at large. So public health agencies and health systems are challenged right now to address both the immediate crisis that we have, but also to step up in ways that focus on preventative services, figuring out how to work harder to connect our healthcare delivery systems to our support systems in communities such as housing or nutrition, and to try to figure out how to change incentives that really address ways to make and keep our population healthier. Our opportunity today is to hear from thought leaders and experts and gain a deeper understanding of some of the levers, including behavioral economics, that can assist us in health policy and health system transformation. Next slide, please. As you can see from our agenda today, in the upcoming session, we'll have the chance to hear keynote remarks on the utility of behavioral economics for aligning incentives within the U.S. healthcare system. And we're very fortunate today to have Dr. Cass Susteen, the Robert Walmsley University professor at Harvard and a senior counselor at the U.S. Department of Homeland Security as a keynote speaker. And also joined by Dr. Kevin Wolf, the director of the University of Pennsylvania's Center for Health Incentives and Behavioral Economics. And he will be providing keynote reactions and comments. And then following the keynote addresses, we're going to have our 1 o'clock session. Joining us will be Nancy Ann DeParle of Capital Connaissance Partners, Dr. Brent James of Stanford University, and Dr. Mitesh Patel of Ascension. And they're going to have a panel that they're discussing what are the practical applications of motivators for individuals, workforce, and the health system as a whole. And then at 1:45, the last panel of the day will focus on the vision for the application of behavioral economics moving forward to become a reality. And Dr. Charlene Wong of Duke University, Dr. Carl Rahn of Health 2047, and Dr. Anya Zay of Odelay of the MD Anderson Cancer Center, and Dr. Sachin Jain of the SCAN Group and Health Plan will provide brief reactions and discuss potential avenues. So it looks like a very exciting day, and I'm so glad all of you can join us. Next slide, please. So just a few housekeeping agendas. Panelists, could you keep your lines muted unless you're going to speak, and then turn your video on. And then those of you who are attending, you have opportunity to add questions or comments. And if we have time in our various sessions, we will try to address some of those. We are going to record this session, and these presentations will be available to you after the event. When you do ask your questions, please follow the format of putting in your name and organization, and if there's someone specific you would like to address the question to. So let me now turn this back over to Jim.
Well, thanks. This first session is the Motivating Health System Transformation in Pandemic Era. And Cass has a hard stop at 12:45. So let's just skip to the kickoff of Cass's presentation and stay with that. And we'll respect that need to leave urgently at 12:45. Cass?
Thank you so much for that. And I'll try to stay on as long as I possibly can. So I'm going to talk at a 10,000 foot level in terms of human beings, what people are like, then about behaviorally informed interventions, and then about sludge and scarcity. So those are the three headings. In terms of our species, here are 5 things we know, 5 behavioral biases. Human beings often suffer and sometimes benefit from present bias, meaning the short term really matters. Today and tomorrow are very salient. The next decade is a foreign country, later land, we're not sure we're going to visit. And the next year may be a foreign place, at least, that we think we're going to visit, but we don't focus on particularly. Patients and people who aren't yet patients, people who are aspiring not to be patients, but will be patients, often are affected by present bias, and that influences their choices and decisions and creates serious health risks. We know, second, that human beings tend to be unrealistically optimistic. This comes as a surprise to many of us who might consider ourselves pessimists, but 90% of people believe that they are safer than the average driver. 100% of people believe that their sense of humor is better than the average sense of humor. That's because people know what's funny, they believe. With respect to health, smokers tend to have a realistic and sometimes inflated sense of the health risks associated with smoking, but they believe that they themselves are less likely to get lung cancer and heart disease than the average non-smoker. Pause over that if you would. That is a vivid and potentially catastrophic illustration of optimistic bias. We know that human beings suffer or benefit from inertia, which means the status quo has a kind of magnetic force. So if people are engaging in certain behavior, even if it risks their health or their safety, they tend to keep doing it. It takes some sort of intervention to overcome inertia, which is not a tribute to human rationality. It's a tribute to bounded rationality, because the magnetic force of inertia outruns the rationality of continuing with the status quo. We know that human beings, including doctors, this has been demonstrated, are subject to what's called availability bias, which means their risk perceptions are affected by what is cognitively available. If something has happened in the recent past, or it's especially visible or memorable, then probability judgments can be affected accordingly, which can lead to hysteria in cases in which the risk is not statistically very large, but where the incident is top of mind. It can also lead to complacency where the risk is statistically large, but is not top of mind. We know, fifth, and I'm going to give you a summary, that human beings suffer or benefit from limited attention, which means that the number of things that are visible to us or on our view screen is a small set of the number of things that are available cognitively but not seen. And that's true of each of us at this very moment, where I am looking at a subset of things that are actually on my broad view screen right now. And so I hope are you. That's how the mind works. The fact that our view screens are limited can mean that there are health risks and health solutions that are not attended to, even though they are potentially transformative in the best sense. And that is both a challenge and an opportunity. So we're talking about the 5 worst people, shall we call them, of the apocalypse, 5 behavioral biases: present bias, unrealistic optimism, inertia, availability bias, and limited attention. And these all can get us in serious trouble. Sometimes it's said that human beings are irrational choosers. That's not very nice, as well as not being quite accurate. We are imperfect choosers. End of the first part of 3. Nudges are a form of behaviorally informed intervention, which Kevin Volpe and others have done extraordinary things with in the medical domain. They are imperfectly understood. Nudges are choice-preserving interventions that allow people to benefit from a kind of steer, which often removes an existing obstacle and which sometimes imposes a little bit of a push in the preferred direction. Nudges are not incentives. If we're talking about material incentives, an economic benefit or an economic cost, that can be effective. It might be effective for behavioral reasons. It might generate salience and thus overcome limited attention. It might counteract unrealistic optimism. It might overcome inertia. So incentives can be behaviorally informed, but nudges are not incentives. Their beauty is that they are not imposing material incentives, but often materially do affect behavior. A canonical nudge, which has, I think, implications for the domain of health, is the GPS device. And what makes the GPS device canonical is that it allows people to decide on their preferred destination, which will frequently be alive, not dead, healthy, not sick, and it tells them how to get there. It also, the GPS device, allows people to say, I don't like your preferred route. But it does give people a nudge in the direction of the route which the experts, in this case, the designers of the relevant program, have chosen as the preferred route. Nudges tend to come in two different categories in the healthcare domain and otherwise. They bear on safety as well as pandemics. They bear on occupational disease as well as treatment, and it's very useful to distinguish them. Some are educative and some are architectural. And if you look at the Affordable Care Act, you can see a great deal of focus both on educative and on architectural nudges. An educative nudge might be a warning or a reminder or a disclosure of information. Of these, reminders deserve particular emphasis, so I'm going to remind you of them. They are a sleeper nudge. If people are given text messages or a phone call to remind them to do something, they might be doctors, they might be nurses, they might be patients, reminders can save lives. And the data we've had over the last years suggests that reminders have a significant impact, in part because they overcome every one of the behavioral biases with which I began. Warnings can also have a terrific effect, especially if they're accompanied by a suggestion of the route by which people can avoid the risks to which they are currently being subjected. Architectural nudges include such things as defaults, automatically enrolling people in something unless they choose to opt out. Forced choosing, as when people are told you have to decide between X and Y if you're going to get something you want. And order effects, as in a list on a menu of which the nudged one is, let's say, the first or the one in the largest font. Default rules, a meta-study shows on average increased participation rates by 26%. That's a massive impact from shifting to opt-in to opt-out from opt-in. Simplification is a cousin of automaticity. Simplification is an architectural solution which often has a large effect on outcomes. Of the list of nudges, both educative and architectural, two general ideas deserve pride of place. One is making things easier, and frequently it's thought that we should push people into a course of action. The better idea is to figure out why aren't they doing it anyway and to remove the obstacle. That is a form of easing choice. If the healthier choice is the easier choice, the dividends can be massive. The second idea that has pride of place is social norms, which are a form of educative nudge, both with doctors and with patients. When people are informed that most people are doing X, then the likelihood that people will do X tends to jump. And indeed, it's the case that if most people aren't doing X, so you can't use the majority norm, you can't honestly use it as a nudge. If it's the case that people are increasingly doing X, or if there's an emerging norm in favor of X, there's data suggesting that that tends to create a self-fulfilling prophecy. And I regard that as one of the most exciting findings in behavioral economics in the last decade. Emphasis on the emerging norm tends to change behavior because people think, I guess, that what's emerging has some sort of epistemic warrant, and they tend to think they don't want to be on the wrong side of history. Okay, done with nudging. Last part is sludge. The basic concept here is that the healthcare system and health-related decisions are often pervaded by administrative burdens, barriers, obstacles, waiting time, reporting requirements, forms that are confusing, which tend to have adverse effects on the healthcare system, on doctors and nurses and patients. I'll give you a number, and I hope if you remember anything from these remarks, it's the number. The United States government, according to a recent assessment by the United States government, imposes 11 billion annual hours in paperwork burdens on the American people. 11 billion. A significant chunk of that comes from burdens in the healthcare system imposed on all those who participate in the healthcare system. And David Cutler has shown that some of the less than optimal features of the American healthcare system are driven by the sheer magnitude of sludge imposed on the system. For rational actors, sludge is often a wall separating people between some outcome and where they are now. Sludge can be seen as a kind of Stephen King novel version of a GPS device, that it's the anti-GPS device. It does the opposite. It prevents people from getting where they're going to go. That's true for fully rational actors, for people who are subject to such behavioral biases as present bias, inertia, and unrealistic optimism. Sludge is cruel. It's also the case, and this is the substantive point I'd like to leave you with, that human beings have scarcity of cognitive resources, not just scarcity of money, also scarcity of cognitive resources. And if you are sick or poor or elderly or just struggling with something, maybe depression or anxiety, the ability to navigate sludge is severely compromised, which means that sludge is not only a question of social welfare writ large, it's also a question of social justice. What's needed are sludge audits in which informally and formally we audit the level of administrative burden imposed on persons. Removal of sludge is often much better than increasing economic incentives, because removing the obstacle is often the best way to pave a path towards healthier outcomes. My final words for you are a question, which maybe has particular poignancy in this year, which is, what is the thing that human beings are most blessed to have? And those of us who know people who've lost their lives from COVID-19 or some associated threat in the last year, that question is something we ask ourselves. The answer to the question, I think, in this year is a four-letter word, and it doesn't begin with L, it begins with T. It's time. That's the thing we're most blessed to have. Let's find, shall we, ways with the aid of behavioral economics, ways to give other people more of that. Thank you.
Cass, thank you. I know you have just a few minutes left. There was one clarification asked, and that was when you were talking about the imposition of hours of paperwork. Was that billion or million?
Billion.
Billion.
Billion. Million. So the Department of Homeland Security, where I work, according to this data, imposes 195 million hours in paperwork requirements. That's one department. And that's a lot of millions. The Department of Health and Human Services crushes that.
Another question had to deal with the fact that, there seems to be diminishing trust in science and increasing polarization. And does that have an effect or not? And whether educative nudges or architectural nudges would be more or less effective in health and well-being?
Yes, it does, but it's maybe not the first thing to worry over or the largest thing to worry over. If people are given a reminder that they have an appointment next week, the likely reaction is not, that's being sent to me by the Russians. And if people are told something about the need to take their medicine, every day, they're unlikely to think that's coming from someone of a political party I don't like. So in terms of the day-to-day operation of health and safety, this is not the most serious problem, though in terms of large issues like getting vaccinated and thinking about certain kinds of risks, let's say, political polarization is a big problem. And the best response to that is to find trusted validators, people who are trusted among those who would be inclined to dismiss the so-called experts as in someone's pocket or having an agenda.
And in terms of the list of ways of influencing behaviors, if you think about different domains, institutional domain on one hand, patient on the other, provider on the other, does your priority list change in terms of what might be most effective between these different domains?
It's a great question. I want to think, what is the problem that the intervention is intended to solve? If the problem is patients aren't adhering to the treatment that's been prescribed, then we know there are things that tend to work. Reminders are helpful. And there's an assortment of things. If the question is whether nurses are doing the 5 things that they're supposed to do, then there's another set of interventions. So I want to go maybe less category of personnel than concrete problem.
And lastly, recognizing you have limited time, I just, on a personal level, I mean, you're a patient at some point in your life. How do you use the strength of this knowledge to improve your own health?
Well, I tend to do a lot of racket sports, but that's partly because I really enjoy them, as well as I know that they're healthy. And I've been blessed not to have much in the way of medical anything. But I try to think that even if, on the rare occasions in which I have, I've tried to think as statistically minded as I possibly can. And if there's a choice to be made between doing X and Y, what are the outcomes and what are the probabilities? And let's do a little multiplying, rather than thinking about my feelings.
Well, thank you. I mean, this was terrific, and we're really grateful that you could join us and recognize that you have a timeline. We're just grateful for the time that we got. This was terrific. Thank you, Cass.
Very grateful to you. Thanks, everyone.
Next, we go to Kevin Volpe. And Kevin is a founding director of the Center for Health Incentives and Behavioral Economics and the division chief of health policy for the Department of Medical Ethics and Policy, and the Pauley President's Distinguished Professor of Medicine at the Perelman School of Medicine and Healthcare Management at the Wharton School, all at the University of Pennsylvania, of course, a member of the National Academy of Medicine, editorial member for New England Journal Catalyst, and a principal of the behavioral economics consulting firm VAL Health. And Kevin has done just groundbreaking work on incentives and how they play out in healthcare for both patients as well as providers. Kevin?
Thanks very much, Jim. Cass is always a tough act to follow, but I'll try to amplify some of the concepts he talked about and describe some of the ways in which those insights are being used to improve health and healthcare. So let's go to the next slide. A few years ago, I wrote this paper with David Ash, and it was about this concept of halfway technologies, which are in essence those that don't eliminate diseases, but can postpone their effects. So we can think about paradigms like cardiovascular, chronic disease management. And we know from lots of evidence that if we had perfect adherence to all the evidence-based therapies, we could actually reduce the rate, in theory, of cardiovascular events by something like 70 to 80%. But yet we know that in the year following a heart attack, that adherence rates to the recommended cocktail of medications is only about 45%. And I think examples like this, and there are countless examples, highlight that behavior is really the final common pathway as we think about trying to improve health and health outcomes. And it's really behavior among both clinicians and among patients, because when you have adherence rates of 45%, you have to ask yourself the question, why is it that that's the best that we can do? Let's go to the next slide. Part of the challenge here is that we've typically thought about people as being perfectly rational, and we've thought if we could just educate patients on what to do, providing them with information, provide some incentives, and just layer on increasingly complex interventions, that would lead us to having the desired behaviors. And I think we all know that that's not true, and that's a lot of what behavioral economics has contributed over the past few decades to better understanding. So going to the next slide, what we really have is a paradigm in which the mind is more like a high resistance pathway, and we've all developed behavioral reflexes that in essence bypass cognition. So we can think, instead of just providing information about using choice architecture and defaults creatively, we can think, instead of just providing financial incentives, how to make those more behavioral. And then, as Cass was saying about sludge and the terrible problems we have with complexity, we can think about really the antidote to that is really making things as simple as possible, given that we all have bounded rationality and limited bandwidth. Next slide. So I'm going to talk about this in three main categories. One is the notion of changing defaults. And I want to start with this because often making things easier to do for patients and clinicians is more effective than changing their financial incentives. And you'll see as I talk through this, there's some things where the types of effect sizes you see are not effect sizes you could change by changing how people are paid. Then we'll talk a little bit about financial incentives. And then I want to talk separately about simplifying complicated processes, because the sludge that Cass talked about is just such a central issue. I think we have to continuously remind ourselves of this, because that in itself creates a real opportunity for improvement. Let's go to the next slide. So many of you have probably seen this example before, and it's a classic within the field of behavioral economics, which Eric Johnson and Noah Goldstein published in Science a number of years ago. And this basically shows the difference in organ donor registration rates in Western European countries. On the left in orange are countries which have an opt-in. In the right in green are countries where you're presumed to want to be an organ donor unless you opt out. And you can see dramatic differences here. Again, hard to imagine achieving this kind of difference through any kind of financial incentive. But then translating that to improving people's health behavior is a bit more challenging. We can't just take everyone who's obese and say, let's put you in a weight loss program by default and see what happens, because we know we wouldn't be that successful at engaging people and helping them lose weight. So going to the next slide, one of the things we've tried to do is to think about, that said, how do you modify the enrollment process for programs? This was an example of a program we did where we had people with patients with poorly controlled diabetes, and we offered them free participation in a program that provided remote monitoring of their blood sugar. And we reframed the invitation from an opt-in to an opt-out. And we were able to roughly triple the enrollment rates and had similar improvements in glycemic control. So I think there is a reframing that can actually be quite useful when we think about programs and programs where the benefits are much greater than risk in terms of patient participation. Next slide. We can also think, though, about how this can influence clinician behavior. And I know Mitesh is going to talk a bit about this. He was the architect of this study. And this is an important example because we had struggled for years as a health system with generic prescribing. And you can see generic prescribing rates are all over the map. Once the default was changed to generics, if you press next slide, you'll see the rate of generic prescribing went to almost 100% overnight. And this saved our health system tens of millions of dollars within a relatively short period of time. Next slide. Sometimes you can't just default people, though, into the decision you'd like them to make. And this is an example of some work we did a number of years ago with CVS, where we worked on just making more salient to people the convenience of being in an automatic refill program. So on the bottom here, press 1 if you prefer to refill your prescriptions by yourself each time, or press 2 if you'd prefer for us to do it for you automatically. And this roughly doubled the rate at which people signed up for the automatic refill program. CVS has used this in tens of millions of members, and it just makes it easier for people without actually defaulting them into the automatic refill program. And the reason they couldn't do that was they said, every time we send out these refills, we have to charge people's credit cards. People would be furious if we did that without their explicit authorization. So you can think about a sort of array of different approaches here, depending on the context that can be brought into play. Now, moving on to the next slide, and the slide after that, we can talk a bit about financial incentives. And this obviously came into play in a very large way with COVID this summer, where as voluntary efforts to get people to get vaccinated stalled, states around the country turned to the use of incentives. And if we hit the next slide button, one of the salient or important findings in behavioral economics has been around probability weighting, where we see that people typically, next slide, with probabilities near 0 tend to overweight those probabilities and think they're more likely than they actually are. And this underlies the popularity of lotteries in general, and is probably a big part of the reason why a lot of states turn to lotteries, because they could offer million-dollar prizes. But if you're offering a few million-dollar prizes in a state of 10 million people, the cost of that per person is actually quite small. So moving to the next slide, despite the hype about this and the excitement, the reality was considerably more challenging. We wrote an article, I wrote an article with Carolyn Canusio about this on incentives for immunity. Going to the next slide, I think there were a lot of good ideas behind this, and you can think about reasons why we might consider incentives. There are positive externalities. So in a free market, people don't adequately consider the benefit to others in making decisions. And you can think about pollution as a prime example of the opposite, a negative externality where we tend to find polluters. But you can also think about other reasons why we might provide incentives to get COVID vaccinations to offset the costs for people who have to take time off from work or arrange childcare. There's obviously enormous potential for cost savings. Economists have estimated the total cost of COVID to the US of about $16 trillion. So if we can shorten the epidemic, that would have obviously been a good thing. And then we know from lots of other health contexts that incentives have been shown to be pretty effective in increasing the rate of healthy behavior. But moving to the next slide, I think there's some challenges here. And when we and others have looked at the evidence from around the country, the paper on the left is a paper led by Harsha Thirumarthy looking at a number of different states and the effectiveness or lack thereof of their incentive programs. The graph on the right from the Philly Vax Sweepstakes, that was a program our team set up in Philadelphia where we gave away a couple of $50,000 prizes as well as a number of smaller prizes, is in essence, these incentives didn't work. And there's a more complicated story here, but I think the simple answer is that these were largely deployed at a point in the pandemic at which those who weren't vaccinated had made up their minds. So incentives with a small expected value weren't going to work. Next slide. And what we've seen as a response is an increasingly stronger form of incentives, which are in essence policy interventions that were really needed. And you can think about employer mandates as being a really strong form of incentive because, of course, you're going to lose your job if you don't get vaccinated. But we see both in the US and Europe and other countries a lot of use of conditional incentives, where in essence, if you want to fully participate, if you want to travel to the European Union, if you wanted to attend the NFL draft in person, a lot of cities, if you want to go to concerts, restaurants, et cetera, you have to be vaccinated. You can also think about other approaches like raising health insurance premiums on the unvaccinated. And now we're starting to see, just in very recent time, various other countries moving further down this spectrum. So Austria started placing unvaccinated people in partial lockdown. They now have mandates for vaccination nationally by February. They haven't specified the fines yet. Greece just announced yesterday they're going to require people over the age of 60 to get vaccinated. Otherwise, they'll pay a fine of about $1,400 a month. $140 a month. So it's enough of a mandate that it will have teeth. And I think what we've clearly seen is that these types of incentives, stick type incentives, are probably what would be needed in a situation like this. The carrot type incentives with low expected value clearly were not enough. But I want to move to the next slide and just comment briefly on some of where we are in terms of clinician incentives. And this was a slide that my colleague Amal Navat, who's part of MedPAC, put together for the CHIVE Advisory Board a week ago. And I think it's important for us to pause here and recognize that for the most part, most providers still aren't facing value-based incentives. And if you look at the graph on the left, you can see traditional fee-for-service, and pay-for-performance. That's about 65% right there. And then many of the other mechanisms, they're basically primarily priced, reconciled from retrospective fee-for-service payments. So we have fee schedules that often reward providers for providing low-value care. The relative value units themselves are largely based on cost, not value. So it's really important to recognize here that while behavioral economics really tries to think carefully about the various biases Cass described affect human decision-making, if the underlying economic incentives are incenting activities we don't want to encourage, it's very hard to overcome that. And I think this is really important for us all to recognize. Next slide. So I want to move and just talk very briefly about simplifying processes, because I see this as the antidote for some of what Cass described as sludge. And moving to the next slide, one of the challenges we have is often programs are just too complicated. And I wanted to highlight, this was a program, COVID Watch, that some colleagues at the Penn Medicine Innovation Center created, which we were really quite proud of. And it was featured in the New England Journal Catalyst side by side with a program from Northwestern. And the Northwestern program, I think, was also a laudable program, but the main difference was that was using humans as the workforce, whereas COVID Watch was a program that was created, which was basically a very simple text messaging engine where patients who clinicians were concerned about but didn't want to admit to the hospital were sent home, remotely monitored, twice a day with text messages. And if they were concerned about their breathing, there was a code for them to type in which case a nurse would call them right away. So very, very simple. And you can see here that, of course, when you have an automated algorithm like this, you can monitor people 24/7. You need a lot less daily staff hours. You can save millions of dollars. This program had a really high net promoter score. And most importantly, it actually saved a lot of lives relative to a control group of other Penn patients. It's not relative to the Northwestern group. I want to highlight that. But it saved 68% of deaths on estimate relative to a comparison group of patients. And so, again, like keeping it really simple is often the best way to go. Moving to the next slide, there are lots of examples we could point to here. There's just some work led by Jalpa Doshi on prescription synchronization. Lots of patients are on 10, 15 medications a day. They struggle a lot with just simple acts like refilling because the refills are all due on different dates. This was some work with Humana, basically showed that for patients with low adherence, you could increase adherence rates by about 13 percentage points just by synchronizing the dates of the prescription. And then the next slide, I want to just give another example to close, which is health plan design itself. And we know that these health plan designs are very confusing. They assume people are perfectly rational and can read through dozens of pages of small print like this and understand all the underlying incentives. But the reality, of course, is that people don't. As Cass said, people have limited bandwidth, and very few people, if any, are going to understand all these details and really commit them to memory. So when they're trying to decide, do I go to urgent care? Do I go to the emergency room? They're going to know what the difference in cost would be. Furthermore, going to the next slide, it's actually pretty much impossible to calculate that difference. So there's a veritable alphabet soup of different kinds of incentives that are in play. And if I'm trying to calculate how much is 10% of an ER visit, it's basically impossible to do because I don't know what 100% of the price is going to be ahead of time. And then depending on how much I've spent this plan year, there's no way for me to know what the combination of my deductible and coinsurance are going to add up to. So we've worked now with a number of health plans in creating simple health plans, which are co-payment only. And I think that you can think about that as a paradigm of sorts for trying to just make it easier for patients to recognize, here are the underlying incentives. If I want to go to urgent care, it's $75. If I'm going to go to the emergency room, it might be $350. But at least I understand what the trade-off is, and it's easy for me to understand. So moving to the next slide, there's a lot of ways in which behavioral science can be helpful in terms of motivating health system transformation. As I said, I've tried to highlight some of the areas besides financial incentives because I think we've seen in a number of contexts that changing the defaults, choice architecture, making things simpler, really, really important, independent of whatever is done with financial incentives. Financial incentives obviously also play a big role, but there's a lot we need to do to think about the underlying economic incentives and how to make those more appropriately targeted so that any behavioral twists we add to that can make the program achieve the desired goals. So let me go to the next slide and happy to stop here and take any questions.
Thanks very much, Kevin. That was great. Let me just ask you, when you work with the health plans to make something simpler, what was the incentive for them? Some of the complexity, people argue, is that they need to differentiate themselves from each other. So what was your experience with that?
Well, we had a really good experience with Humana a number of years ago, creating a health plan called Humana Simplicity. And it was something which leadership just got interested in doing. And it's been a plan which has now been in place for a number of years and attracted quite a few members. I think it provides a differentiator that allows them to appeal to consumers in a way which perhaps they couldn't otherwise.
And if you think of these various examples that you used and the health system as it's currently set up, where are we fouling out, so to speak, in the way we have incentives set up that would be the sort of the easier change to make and to swallow for the health system?
Well, it's a complicated question to answer, Jim. I think we could start with the slide I showed in terms of clinician payment. You know, there's a lot of rhetoric about moving to value, but if you look at where the dollars are going, it's still largely based on fee for service, and then fee for service, isn't really based on value, it's based on cost. So if we really want to drive to value, we have to rethink both of those in terms of what the fee for service payments are based on, and then how we might really think about in moving more clinical groups towards more of a value-based framework. I think on the patient side, one of the challenges is that benefit design is a little bit of a crude instrument to change behavior because you have to look at what is true of people on average, and it's very hard because what might be high value for a given patient might be low value for other patients or vice versa. And so you're sort of limited to making changes where something is universally low value, universally high value, but the reality is many clinical treatments, diagnostic tests, it all depends on the given patient and the indications.
And at a given institution that's hardwired to these external programs of payers, CMS, and whatnot, where is the low-hanging fruit to make progress for an institution that is part of this, hardwired to this web?
Well, I'd come back to something Cass said about the question being, what are the primary goals? And I think you have to step back and think less categorically about groups and more about what you're trying to achieve. And then what are the different tools you have to try to influence behavior? And then within each of them, how do you best optimize the way those programs are designed and configured to achieve your goals?
A question came in from someone dialing in, asking basically, in light of what you've presented, Kevin, isn't plain Medicare, where copays and deductibles are fixed and simple, better than plans, which are designed to be more complex?
I don't know if I would say they're designed to be more complex. I think many plans have evolved in a direction that just continuously has added complexity because people often don't recognize the cost of sludge. There's good ideas behind adding programs and making things more complex, but there's often not a comparable effort to remove programs and make things simpler. So I think there are pros and cons to different types of plan designs. I'd love it if we thought more about using copayment only systems, because I think it does give the patient a chance to really understand what things cost in a very predictable way, which you could never get to using deductibles and coinsurance.
Well, recognizing we're at the top of the hour, I mean, these were fantastic presentations by Cass and yourself, Kevin, and we're grateful for the work you do and for joining us today. Perhaps it would be good now with a clap to thank you, and then shift to Diane to facilitate the next session. So thanks again.
Thanks for having me.
Oh, and thanks, Jim, and thanks to Cass and Kevin for really terrific presentations. So now we're going to turn to our panel called Action for Individual and Workforce-Driven Change. And this panel will provide some details surrounding the practical implication of incentive structure to better align the behavior of individuals, workforce, and the system as a whole. And with health system effectiveness, efficiency, equity, and continuous learning in mind, we turn to our really terrific panel. So we have the privilege to have a panel of experts who will help us and put some of these ideas to the test in terms of what they're seeing happen in their respective spaces. So let me tell you about our panel. We have Nancy Ann DeParle, and she is a managing partner and co-founder of Consonance Capital Partners. Prior to CCP, she was assistant to the president and deputy chief of staff for policy in the Obama White House from 2011 to 2013. And she served as counselor to the president and director of the White House Office of Healthcare Reform from 2009 to 2011. She currently serves on the board of directors of Sellers Dorsey Psychiatric Medical Care, HCA Healthcare, CVS Health, and she's also a member of the Duke University Board of Trustees and a National Academy of Medicine member. So we're excited to hear from Nancy. We're also going to hear from Brent James. He is a clinical professor at the Clinical Excellence Research Center, Department of Medicine, Stanford University School of Medicine, and he is known internationally for his work in quality improvement, patient safety, and the infrastructure that underlies successful improvement efforts such as culture change, data systems, payment methods, and management's role. He's a member of the National Academy of Medicine, and he serves on several not-for-profit boards dedicated to clinical improvement and patient safety. He was formerly Chief Quality Officer and Executive Director of the Institute for Healthcare Delivery Research at Intermountain Healthcare, based in Salt Lake City, Utah. And our third panel member is Mitesh Patel, and he's a physician executive and behavioral scientist. He is currently Vice President for Clinical Transformation and National Lead for Behavioral Insights at Ascension. He is also the Ralph Muller Presidential Professor at the Perelman School of Medicine and the Wharton School at the University of Pennsylvania. Dr. Patel was the founding director of the Penn Medicine Nudge Unit. I love that name. The world's first behavioral design team embedded within a health system. His work has been featured in numerous media outlets, including the New York Times, the NBC Today Show, Wall Street Journal, The Economist, NPR, CNN, many, many places. So what I'd like to do first, if I could, is ask Nancy to begin. Each speaker is going to take 7 or 8 minutes, and then we'll have time to pose some questions. So Nancy, if you don't mind starting.
Sure. Thanks, Diane. Happy to be here today. I am going to take us back up to 10,000 feet as Cass Sunstein was talking about, because my comments are mostly in the realm of my experience in the realpolitik of policymaking, as you might imagine, given my experience at the White House, driving the process that led to the Affordable Care Act. But actually, and can you go to my first slide, Allison? Actually, my experience started way back before that. And it taught me a lot about the importance of politics in these kinds of choices and why nudging can be hard to do. And I'll talk about some early attempts that I undertook to use what I don't even think I knew was behavioral economics at the time, to deal with sludge and to try to do a nudge or two, some of which were pretty successful. And then I'll talk about some later attempts that so far have had mixed success, and some that we left on the cutting room floor with respect to the Affordable Care Act. So the first one here is, this is a bit of a show and tell of what Cass was talking about with respect to sludge. On the left, you see the Tennessee Department of Human Services when I was running it back in the 80s. There was one large office in Memphis, even though that is, one of the most highly concentrated areas of poverty in the US. And the Department of Human Services did the eligibility determination for the so-called welfare program, AFDC, as we used to call it, the Aid to Families with Dependent Children, and also did the eligibility determination for Medicaid and for food stamps. And to sign up for any of those 3 programs, you had to go sit in that waiting room, which was an abandoned Big K department store, if anyone remembers those. It took up a whole, basically, city block. There was a big parking lot in front of it. You had to sit there sort of all day until your name was called. It's worse than the DMV for those of us who go to the DMV in this area, at least. It defines sludge and defines, honestly, desperation, I thought. Behind that blue wall are hundreds of cubicles where the 1,000+ caseworkers sat. And if your name was called, you would go back and sit there and fill out by hand at that point, mostly, even though the caseworkers themselves could enter things into a computer. You would mostly fill out by hand 3 separate applications: food stamps, Medicaid, and AFDC. And when I started trying to fix that, I asked to meet with the 3 federal agencies that, two parts of HHS and another part of the Department of Agriculture, the Food and Nutrition Service. I asked to meet with the regional offices to talk about designing a system that would put the 3 different forms of aid, cash aid and food stamp aid, together into one system online. And I couldn't even get the 3 agencies to meet with me at the same time in Atlanta. That was where our regional office was. So that's sort of where it started. And I got frustrated with that. We did eventually redo the eligibility determination process, but I got frustrated with it. And so I started working on making this, and I don't think you can quite see this, but this is a 60-page application form for Medicaid into something simpler. And then I did something which at that point no other state had done, which is to allow people to sign up for Medicaid when they were in the hospital. We were spending millions and millions of dollars on disproportionate share payments to hospitals at that time. This is before TennCare, the program that expanded Medicaid, and used some of those disproportionate share dollars to pay for actual enrollments in healthcare, Medicaid. But we were spending millions of dollars, and hospitals were seeing and admitting millions of patients, hundreds of patients, thousands of patients without coverage who were actually eligible. And part of the reason was because they'd have to go to that office I showed you there to sign up. And who has time for that? Who wants to do that? There's nothing about that situation that encourages you to do anything when you can still show up at the hospital. So I worked with the Regional Medical Center, which is the big safety net hospital in Memphis, to arrange to have eligibility workers who would be outstationed at their hospital. And they didn't literally go to the bedside. That's a photo that I got online. They didn't literally do that, but they were outstationed there. They could come to your room if you asked. They could sign you up. The Medicaid law would allow people to be covered on a backdated basis, so they'd be considered to be covered from when they went into the hospital. It was not too hard to sell the administrator of the Regional Medical Center, the MED, as we called it, on this idea. It was somewhat difficult for me to sell the governor on the idea, because as he sat there and looked at me, he said, "So wait a minute, let me get this straight. You want me to put eligibility workers into the hospital to get more people on Medicaid, which is going to increase our costs. That doesn't make sense." And I had to make the arguments to him about why it could save money, it would keep people out of the emergency room if they had coverage. And of course, the federal state partnership in the financing of Medicaid being what it is, that in fact, the federal government, we, the taxpayers in other states, will be paying for 65, 68% of every dollar that was spent on those people. But it would be bringing the dollars to the hospital, reducing charity care. I eventually convinced him to do that. And I think we were the first state in the nation to do it. So that was a relatively successful experiment in this. Next slide, Allison. So then fast forward to when I was running CMS in the late 90s. And we were working on some really difficult problems with respect to the quality of nursing homes and just some very bad situations that had occurred. And I'd like to say that's in the rearview mirror, but of course it isn't. We had data at that point about really only about the surveys, the annual survey and recertification of nursing homes that's conducted by states on delegation from CMS. And if you've ever looked at that data, it's not very good. It covers things like whether someone left the wrong kind of cleanser out in a sink in a common bathroom, that kind of thing that could be harmful. You've seen similar information about surveys of hospitals, I suspect the people in this meeting have. In any event, it's not great information, but it's something. It tells you something about the quality of a nursing home. And if you failed the survey, that's up there, so that tells you something. So I decided, without really asking anyone, that I would just throw that up on the web. So we had the very first up on the web in 98, we called it Nursing Home Compare. And you could search by zip code, get information about nursing homes, and it would give you, again, I'm embarrassed, at the appalling lack of data that we had, but that truly went to quality, but we had something, so we put that up there. So the question I had was, would this information about quality change consumers' choice of nursing homes. And that's what I really hoped, was that families and consumers who were faced with a nursing home choice would look at that information and make a decision not to go to the nursing home that had, we had displayed their results on the survey by a primitive form of a star rating. So I was hoping that they'd look at that and realize that this particular nursing home had failed the survey, whereas the one, 2 blocks away had not, and they would make choices based on that. What we found, at least in the couple of years after that, where I followed it more closely, was that the answer is no. Information about quality, at least at that point, and at least with the information that we had, which, as I said, was not very good, didn't change consumers' choice of nursing homes. In fact, the only thing that really seemed to affect their choice was location. Location, 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 as we've all heard. That was the thing that families were looking for. What nursing home was close to their family. And to be fair, that's not a crazy decision, because if your family is going to be watching, you probably are more likely to get quality care in a nursing home. But here's what was interesting about this data to me. Again, just throwing it up there on the web. A couple of nursing home chains threatened to sue us. People were, a lot of the industry was upset about it. I'm sure I got some very stern letters from the trade associations. But then I started getting calls from them, from nursing homes, saying, hey, the data about my nursing home on Smith Street isn't up to date. We had a survey 3 weeks ago, and I want that data up there. I was kind of curious about that. So I started asking them, well, that's interesting that you want it updated. I guess we're lagging behind. Why are you interested? And it turned out that they were studying the information. All of them were looking at it and at their own information and at each other's information. It was the first time they had been able to see it, and they were competing with one another to do better. So that was a happy sort of outgrowth of throwing that information up there. It may not have changed directly the way consumers made their initial choices, but having that information about quality and requiring the disclosure of it did in fact lift quality a small amount, because it caused the nursing homes themselves to pay attention to it and to try to do better. And that's maybe a part of, I don't recall whether that was one of the human nature qualities that Cass talked about, but that was one that I found to be the case here.
Nancy, these are incredibly interesting examples of how, when you really do start sharing data, it makes a big difference. And I guess we're going to get to hit a little bit more from also Brent James about quality intersection. I think I'd like to move to Brent if he's available now. I think
I'm available, Diane.
Great.
So next slide for me, please, and then quickly skip past the next two. It's just a header and a disclosure slide. When we get to those, next one, I plan to cover 3 areas. Go back one. I want to talk about algorithmic versus heuristic work, some unexamined but incorrect assumptions, and risk averse incentives. Now, to frame this, I was dealing with clinicians, physicians and nurses, pharmacists, therapists, and we were really trying to get the care right. So I'm going to talk at that level of a system, the things that worked with frontline care providers to get them on board. It's interesting. I wish I'd had all that fine theory that we just heard. It would have been delightful, very, very useful to have it. We kind of worked it out, just as Nancy Ann was saying, on the fly, the hard way. If I had a single theme for it, it would be this. We tried to make it really easy to do it right. Didn't have to change their values, their work ethic, their commitment to their patients. They were very hardworking, deeply committed, really smart, well-trained people. But how could you make it really easy to do it right in a very complex environment? So the first, algorithmic versus heuristic work. Next slide. This already comes from Dan Pink at Stanford. Jeff Pfeffer has written a great book chapter with Robert Sutton on the same topic. 2 classes of activities that you might undertake. The first is called algorithmic. You just have to follow an established set of instructions down a single pathway to achieve one conclusion. So it's completely predefinable. That stands in contrast to heuristic work, where you have to adjust on the fly, adjust and create on the fly. Clinical care delivery is massively heuristic. No two patients are quite the same. It's a very complex environment, so people have to adjust. Oh, it turns out that financial incentives at the front line work as advertised for algorithmic processes. Some healthcare processes are algorithmic, preparing a patient room, for example, preparing food. Care delivery is heuristic. The trouble is, next slide, for heuristic processes, financial incentives actively damage performance, actively and significantly damage performance. Raises a question, next slide. What does work in a heuristic setting? Turns out it's professional values, what's called intrinsic motivation. You try to get fair pay. According to Dan Pink, you pay enough to take money off the table so that people aren't thinking about money. Then 3 factors apply: autonomy, mastery, and purpose. Autonomy, that ability to experiment, to create, essential in a heuristic environment. You can't function without it. Mastery, we really do want to be the top of our field. And then that purpose element, maybe that's the most important, doing things that truly matter, making a real contribution, a purpose-driven life. That worked for us in spades. Is that focus on shared professional values as a primary motivator? Next slide. Well, it turns out that if you're using financial incentives, there are a couple of unexamined assumptions. The first is that clinical data systems can adequately assess comparative performance. The problem comes when you start to correctly statistically calculate confidence intervals around rankings. You end up with dramatically wide confidence intervals. They can't rank very accurately in most circumstances. There are a couple where they can, but they're fairly rare, you see. So it's really hard to say who should get the incentive in a fair way. Somewhere along the line, though, I would agree that perhaps at an institutional level, financial incentives make sense. But somewhere along the line, but before you get to the front line, somebody has to change the method. One of my real frustrations is watching senior leadership teams in healthcare delivery systems accept the old mantra, incorrect, that financial incentives will drive appropriate behaviors down at the front line. With strong enough incentives, they believe somebody, who knows who, will somehow figure it out. They're really believing that the primary reason for poor performance is motivation, when the actual causes are increasing complexity, a system that relies primarily on human memory for execution in a very complex environment, and poor process level transparency so frontline workers can connect action to outcome. Next slide. When you use those sorts of systems to try to rank and then financially incent at the front line, well, Deming talked about it extensively. It's been extremely well documented, as it turns out. There are 3 ways that you can meet a target. First is you actually improve real performance. Requires vision, tools, times, resources. Far more common, teach to the test. Sub-optimize the system by working harder under the measurement spotlight, but it comes at the expense of other areas that are not under the spotlight, and your overall quality actually declines. The big one, though, number 3, game the data. I've been surprised at how many systems, care delivery systems, actually now call it clinical documentation improvement. Maybe that's partly teach to the test, but gaming the data, the examples are endless. So did the data change? Yes. Do the actual patient outcomes change? No. That's actually been studied and fairly well documented, just in passing. The key factor is to match the incentives to the level. When we focused on professional values, a purpose-driven life, mastery, necessary autonomy, when we made the pay fair so that people weren't thinking about money, real impact on a broad scale with measurable changes in patient outcomes that made sense. With that, I'm going to quit and allow this to move on to the next presenter. Thanks.
Thank you very much. And Mitesh, I believe you are up next.
Great, thank you. I'm going to talk about using nudges to improve the delivery of healthcare. I'll cover a quick background and then spend most of the time talking about 3 key lessons that we've learned from a lot of the work that we did in Penn Medicine. Go to the next slide. We just like to start with this slide with the note that human behavior is the final common pathway for the application of nearly every advance in medicine. No matter how effective a medication, how protective a vaccine, or how targeted we can get a therapy or molecule to be, two things have to happen for it to translate into any benefit for patients. And that involves the dynamic between clinicians and the care team and patients. Clinicians need to be able to recognize that a patient meets criteria for a new treatment or test and offer or prescribe it. And the patient needs to understand what that means for them and then use it as directed. If neither of those things happen, let's say a clinician doesn't prescribe a statin or a patient doesn't take it, it's obviously not going to translate into any benefit for patients. Next slide. In healthcare, this dynamic breaks down quite often. Sometimes we do too much. There's many references around how a third of healthcare spending is thought to be wasteful or unnecessary. But a lot of the times we don't do enough. Patients will come into the hospital or to a primary care visit and leave without having a discussion around evidence-based medicine that we know can improve their lives or reduce hospital readmissions. In the last decade, 2 technology platforms have expanded widely and been adopted to give us insight into the everyday decisions that are going on and the behaviors of patients. On the health system side, 90% of clinicians use electronic health records. All those decisions that were being made on pen and paper or over the phone or vocally are now inputted through the system. So we can actually see what they are. And it gives us a new choice environment that we can change the way that information is displayed or offered to try to guide clinicians towards evidence-based medicine. For patients, more than 80% of adults in the United States now use the smartphone, and they're essentially glued to these devices wherever they go, which means that we can actually track their behaviors from physical activity to usage of the phone to communicating with family member and friends, obviously with their consent. And then we can also communicate with them. We can intervene through traditional telephone calls or through other methods like patient portals or text messaging. Next slide. So I'm going to go over 3 lessons that we learned from implementing nudges in healthcare at Penn Medicine. You can go to the next slide. So the first is that it's not really a question of whether we should be nudged. We're already being nudged whether we know it or not. And here's a great example. This clinician here, this is a screenshot from the electronic health record, is searching for Coreg, which is a brand name beta blocker. And as any good search engine would do, if you search for Coreg, it's going to show you Coreg. But as you can see, it's listing the brand name prescriptions first and then the generic prescribing prescriptions below that. Clinicians often have maybe a few seconds because they're probably ordering many of these medications for patients and doing it quickly within a 7 or 10-minute visit. And so oftentimes they don't scroll all the way down to prescribe the generic, which we know is the exact same as the brand, but much more affordable. And so we can go to the next slide. You saw some of this in Kevin Volp's talk earlier on how we were able to change this from an opt-in process to an opt-out process simply by adding the dispense as written button checkbox here on the bottom. This is a checkbox that had been on prescription pads for decades, but just didn't make its way over into the initial versions of the electronic health record. This took 1 hour to implement, and as you can see, the change in prescribing went from 75% to 98%, saved about $32 million in unnecessary prescribing in just the first 2 years. And these rates have been sustained ever since this was implemented several years ago. Next slide. The second lesson we've learned is that good nudges are often easily available, but they need strategic attention to identify. So here was the challenge that was brought to us by Sonam Sharma and Justin Beckelman, who are radiation oncologists at Penn Medicine. National guidelines recommend for palliative cancer patients who are at their end of life, they might have days to weeks left to live. If they're receiving radiation for palliative reasons, they should not get alignment with imaging because it doesn't offer benefit, because many of the benefits that accrue from that offer come about many years later. And these tests can be expensive, and in many cases, insurances didn't cover them. But 80% of patients in Penn Medicine were receiving daily imaging. So if you were getting 14 fractions of radiation, you might get 14 CT scans or x-rays. So we can go to the next slide. So they brought us the idea of let's put the price of the test right where you see this blue box on the left. They wanted to put the price here and say, remind clinicians that a CT scan or x-ray is, $2,342 or whatever it might be. And we said, well, physicians know this might get numb over time. It's a lot of information. This is actually half a page of a 3-page document that's embedded within the EHR that was used at the time that had to be filled out. And what we realized in this process was actually the first option was a cone beam CT, CBCT, done daily. So clinicians had gotten in the habit of quickly going through this form, and they were filling out cone beam CT daily for their curative intent patients, also did that for their palliative intent patients. And there was a whole discussion around, do we need to get IT on board? This is a small vendor from an electronic health perspective. How are we going to change this? And we realized this is a Word document. We right-clicked on this button, and then you see what appears on the right-hand side, simple drop-down form field options. You can highlight none and move that to the top, and all of a sudden none becomes the default. This is essentially a free intervention. It took a while to come to this because there was a lot of other things that we thought about, but really shows you how starting with the problem can really unveil new opportunities to make really simple changes. We wanted to test what was the impact of this subtle change compared to all of the other things that were going on, that they were sitting down with all the radiation oncologists, giving them feedback. They were holding grand rounds about this. So we rolled it out as a step wedge cluster randomized trial. You can go to the next slide. And if there's imaging here, if there's animation, you can go through all this. So you can see here on the y-axis is the rates of imaging, on the x-axis is time. They think the goal is about 20%, and you can see in the first 3 quarters with just education and holding grand rounds, there was a little bit of improvement from 70 to 80% down to 60 to 70%. But the big change came in February of 2017, when we flipped a coin and the university practices in blue were randomized to go first. You can see that their imaging rate dropped substantially down to about 25%. And then 3 months later, we rolled this out to the community practices, and you can see their rates dropped as well. Overall, the imaging rates dropped from 68% to about 32%. This meant that 3,000 less imaging tests were being done per year. And something that was actually unanticipated, but we found when we did the evaluation, is that the visit time for patients was reduced by 20%. Now, if you think about it, this is not totally surprising. If patients don't have to go to get imaging, wait for the imaging to be read, and then adjust treatments for that imaging, that's going to save a lot of time. And these are patients who only have weeks to months left to live. And so this is really valuable time for them. It also means the health system can get in more patients because we're oftentimes full, and this creates more capacity. So this was really a win-win all around, and really just needed some strategic attention to realize what the issue was and how we could set up a nudge to address it. Next slide. The third and final kind of takeaway is that, and you've heard this concept of sludge being mentioned before, reducing sludge is really half the battle. This is a project that was brought to us by Shriyad Sumali, a cardiologist at Penn Medicine. Cardiac rehab is an evidence-based pathway that's been demonstrated time and time again to reduce mortality and readmissions by up to 30%. But at our health system and many others across the country, referral rates are low. Only 15% of patients who came in for a heart attack or stroke were being referred to cardiac rehab at the time of discharge. More than a quarter of hospitals in the US refer less than 1/5 of their patients. When we talked to the cardiologists and asked them, would you refer a patient like this for cardiac rehab? They said things like, this is like fluoride in the water. Every patient should get it. It's a structured exercise program with a cardiologist on site. But the process is really hard. We have to fill out a paper form while on rounds that have name, date of birth, medical record number, things we don't know for each patient just on the top of our heads. And then the patients are on their own to identify a rehab center. And then they have to wait on the phone with the insurance companies to figure out if their insurance actually covers that rehab center. And so we tried to change this by reducing a lot of the sludge and automating it. You can go to the next slide. Shriyad Sumali worked with the team to automatically identify which patients should be referred. That was linked to our secure text messaging system. So the care managers on rounds now got a text with the names and locations of the 3 to 4 patients that we needed to stop and have a discussion about cardiac rehab. We restructured the rounding process. So as opposed to being an opt-in question, should this patient get cardiac rehab? It was an opt-out question. Any reason why they shouldn't? The form was completely it was completely printed out from the electronic health record. The data I'm going to show you is when it was still on paper. Now this is thankfully electronic. All the clinician had to do was sign. We can get name, date of birth, home address, all of that information from the EHR. We shouldn't have to write that in while rounding on patients. And then a care manager went and met with the patient, provided them with a vetted list of cardiac rehab centers in proximity to their home with availability and covered by their insurance that our patients had had good experiences with. The care manager called the cardiac rehab center the day of discharge and 30 days later to see if the patient went. And we can, on the next slide, we'll see the results. The intervention hospital in blue compared to the 2 control hospitals in orange. And you can see prior to the intervention, these rates were low, anywhere from 5 to 15%. Afterwards, it simply skyrocketed to 85, 90%. The referral rates net went from 15 to 85%, and these have been sustained. And more importantly, attendance to cardiac rehab by patients went from 5% before the intervention to 40%, an 8-fold increase in cardiac rehab attendance. And if you think about it, we simply just made it easier for clinicians and patients to do what they had wanted to do in the first place. You can go to the next slide. So in summary, medical decisioning is often suboptimal. The design of choice environments influences our behavior significantly. We're already being nudged. It's not a question of whether we should be nudged. It's a question of whether we want to allocate strategic attention to make sure that those nudges are designed to be aligned with our long-term goals. And nudges can improve, as you've seen, the delivery of healthcare if we take a systematic approach to designing, implementing, and testing these interventions. They can steer decisions towards higher value and better patient outcomes. Next slide. That's it. Thank you.
Well, thank you. That was a terrific set of presentations. And we have time for a few questions, and maybe I'll just launch with one of them. So perhaps we could start with the question, and maybe Mitesh, you would take this first, but then we'll go to the other panelists to see what their thoughts are. So prior to and during the pandemic, which behavioral economic strategies do you think have been the most effective at facilitating healthcare alignment, transformation, and which do you think might be the least effective from what we've seen in the last year and a half?
Well, I think, one thing that I think the pandemic has kind of changed our approach. Many health systems have become more apt towards using digital processes to communicate with patients, whether it's virtual visits or it's text messaging, things that only a handful of health systems were doing before, and now basically every health system is doing. I think a lot of the initial focus prior to that was probably most successful in changing choice architecture within the electronic health record, and that remains kind of in place because that's where all the decisions are funneled. But I think the pandemic has created new opportunities to implement remotely monitored programs, communicate with patients within their daily lives, and really engage them where they are to help them improve their healthcare and their health over the long term.
Thank you. Nancy Ann, what is your thought about what's happened during the pandemic and what has been helpful and what hasn't been?
Well, just playing off of what Mitesh just said, I do think there's been a very concentrated focus on reducing friction and sludge. And an example of that is how long it might have taken to go into a doctor's office and get a vaccination in the past or a test. And now CVS, which really had a business in flu shots, but really wasn't doing much else in that regard, and certainly wasn't doing testing of this sort. You can be in and out of there in 5 minutes. The whole scheduling is much easier. There aren't as many forms to fill out. The payment is taken care of. That was a big part of the friction, obviously. So I think that has been one of the learnings. We actually can do this a lot faster. Maybe this is some of what Brent James was talking about, holding ourselves to a higher standard of professionalism, and we can do this.
Mm-hmm. Mm-hmm. Dr. James, what do you think?
I've talked to quite a number of systems actually around the world. COVID presented us with a whole new challenge. We didn't have established opinions really, and what I saw was evidence-based medicine roll out at a whole new level. Very often when you roll out evidence-based medicine, these are the tools you use. For us, it was blended into clinical workflow. Again, make it really easy to do it right. Mitesh and others have filled in the details of how you go about doing it, but it was a broad strategy to make that happen. It adopted very broadly and very rapidly, specifically for patients with hospitalized for COVID-19. Interestingly, some groups said that they were then able to lever that into other areas of care delivery, which I actually believe are more important on the broad scale. Others, I was talking, for example, the Hospital of University of Geneva, great results around COVID-19, but they weren't able then to move it into other aspects of routine care delivery, which I believe will in the long term actually have much higher leverage. So it's a really interesting question. Why were they doing it this method in one area, a new area, and then the same principles didn't seem to move over to areas that were more long established, more habitual, if you will. So a really interesting question around that particular thing. Gave us a little window though, where we could see what it looked like when it worked well.
We have a question from Tony Sun from United Healthcare asking, can we design nudges that are coordinated by payer and provider jointly? Anyone want to take that one?
I'm happy to start. I think there's a really big opportunity to do that. I think we're already doing some of that already, but there's a lot of opportunity to do more of that. If you think about how the health system is moving, the payer and provider landscape are starting to merge in many areas. And certainly each has valuable sets of data, interactions with patients and things that they can bring to the table. And I think there's a huge opportunity for payers and providers to work together to nudge patients in the right direction.
Anyone else want to jump in on that one? Have you seen examples of it or have ideas what would help? Either at the federal level with CMS, who's a payer, of course, or
we did that a bit, Diane, but I don't know if it applies broadly. It was with our own health plan. Intermountain Select Health, of course, was the largest health plan in the region. We did it fairly routinely. For example, we were able to deploy, make it easy to do it right, nudge systems around things like appropriateness indications for use of a cath lab, for diagnostic cath, for stents, for pacemakers, defibrillator system, maybe. And we got the health plans in the region to agree to treat it as pre-auth. And it took a onerous, difficult, truly hated process by the clinicians, the pre-auth process, and reduced it to less than a minute, just check off the indications. Oh, it was established with dramatic changes in patient outcomes. We were already one of the lowest in the nations, but our cath lab use fell by over 22%. It's about, $40 million a year in savings. And all that it took was getting the evidence in front of the clinicians at the point in time they were making the decision.
yeah.
But the health plans agreed to help out with it. They got a real benefit out of it. They got more benefit out of it financially than we did. But yeah, I don't know. Can you do it when it's not your own fully captive health plan? That's a bigger challenge, I think.
Yeah, you have to make sure those incentives are aligned and like yours were and like many others are. So thank you. Nancy, did you want to weigh in on that one?
I was just smiling because I'm remembering how Brent was a hero probably to the health plan here, but he always, he was an expensive guy to have around the provider because he cost them money. He always figured out the right way to be doing something would be usually doing less of it. And when I was his payer, I liked that, but I'm sure he's not the hero at the cath lab, right?
The funny thing was, Nancy Ann, is the reaction of the physicians. I knew them all personally. These were top-end cardiologists, widely respected sometimes on an international level. One of the people who led out on the research around TAVR was one of them. It was sobering. It's a complexity problem. There's a limit to how many things the human mind can handle at one time, and it's a relatively small number. I mean, the shortest list had over 40 factors on it. The longest of those lists of 5 areas had over 90. But the key was getting in front of them, and we knew that we were already low nationally, and we knew that we were pretty good. But it was sobering when you realize, oh, by the way, we already had a system in place to track long-term clinical outcomes. Clinical outcomes improved. We were over-treating patients. It was inappropriate care. And it was humbling, sobering, but in the end, massively professionally gratifying.
Well, and your work on this relates to what the Academy's been doing on value, but your work, I'll never forget, you're appearing in front of MedPAC when I was on MedPAC, and you're making the case that doing the right thing was actually costing your institution money, making it less healthy financially. And that was a part of, I think, our decision to put the foot on the accelerator, moving toward value. We're not there, obviously, as a country or health system, but that was certainly impactful at MedPAC.
You know, when I run the numbers, I get a different number. We had that IOM committee when we were still IOM back in 2010. Our soundbite, I think, was a minimum of 30%, probably over 50% waste in the healthcare system, this sort of waste. And it has to do with the ability to do it right. is what it all has to do with. I get about 65% when I model it. And I think I can defend those models. You know, they're a little controversial. Massive money. So here's the funny thing from a financial incentive. The math is overwhelming. A healthcare system leader right now today would be dramatically further ahead to focus on these sorts of methods and get the care right and harvest back savings from it than any other revenue enhancement strategy you can name. And so one of the things we debate routinely in our department at Stanford at the CERC with Arnie Milstein, why aren't people all over this from a pure financial standpoint? There's huge money to be had within it.
Well, on that optimistic note and that encouragement, I think it sets us up very well for our next panel. And I would like to thank each of you for your terrific presentations. And now turn it back to Jim. Thank you.
Thanks, Diane. And also I want to thank everyone on that last panel. It was great. And the goal of this next session is to build on this conversation and hopefully articulate a vision for health system transformation that is informed by behavioral economic insights, to identify key strategies that leaders can leverage to better align incentive structures with health system efficacy and equity, efficiency. And we've got a lot of lessons already on that end. So to help us along in this direction, we're really privileged to have a panel of experts from across the health system with insight as to the alignment needed for suitable and sustainable and accelerated change. And just brief introductions. Dr. Charlene Wong is an associate professor of pediatrics and public policy at Duke and serves as assistant secretary for children and families at the North Carolina Department of Health and Human Services. She's a practicing primary care pediatrician specializing in adolescent and young adult medicine, also serves as executive director of the North Carolina Integrated Care for Kids, an innovative model serving Medicaid insured children in central North Carolina. A leader in value-based payment models for child and family health, and her work focuses on healthcare transformation, so supporting a more holistic approach to health and well-being. Second, we have Carl Rahn, who's the CEO of First Mile Care and managing director of Health 2047 healthcare venture firm. He's a globally successful entrepreneur and active advisor to CEOs and top management at Fortune 500 companies. He had a 30-year tenure in management at the consumer powerhouse Procter & Gamble. And during that time, he created entirely new brands that are globally revered. Swiffer, Febreze, Mr. Clean Magic Eraser. And as a result of his strategic insights and understanding of consumer behavior, new categories rapidly grew to 1 billion in annual sales. And Carl has transferred his knowledge of consumer behavior to healthcare. Founding CEO of First Mile Care, as mentioned, a company spun out of Health 2047, which focuses on diabetes prevention. Third, Eniaze Ofadile is currently the executive director for clinical transformation at the University of Texas, MD Anderson Cancer Center, and assistant professor in the Department of Plastic Surgery. In his enterprise role, he's tasked with helping define, align, and implement a high-level roadmap for clinical and economic transformation in support of MD Anderson's vision to deliver high-value cancer care. He's also a non-resident scholar in domestic health policy at the Baker Institute, nonpartisan think tank on the campus of Rice. And he was the 2019-2021 Omen Fellow at the National Academy of Medicine. And lastly, Sachin Jain, who's president and CEO of Scan Group and Health Plan, former president and chief executive at CareMore Health. And from 2009 to 2011, Sachin worked in the Obama administration. And there he was senior advisor to Don Berwick when he led the CMMI project there as well. So Sachin is adjunct professor of medicine at Stanford, and a contributor to Forbes. In addition, he serves on the National Board of Directors of America's Health Insurance Plans, the AHIP organization, and a Make-A-Wish Foundation of America. So let me turn to Charlene for her introductory comments.
Thanks so much, Jim, and thanks for the opportunity to present today. So I will be brief in my remarks. I wanted to hit on two key topics as we think about how can we leverage behavioral economics for a healthier future. The first that I'll speak to has been touched on a bit today, but really thinking about how we can combine the financial incentives, and we've heard many examples of that today, as with social incentives. And I know that Cass was responding to a question at the top of the session today on misinformation and mistrust. And I'm going to be giving an example from during the COVID-19 pandemic, when we really saw the importance of being able to encourage and to reward having people who are trusted messengers do that outreach to people in their networks to really help encourage these healthy behaviors that we were seeking to promote. So that's one theme that I wanted to touch on today. And then the second is, as we're thinking about a healthier future, I'm very much a proponent of thinking about integrated whole person health and thinking about how we can design nudges together. And actually the example I will give is going to be an example from the last panel of where we had payers and providers coming together to design nudges to really better address whole person health. And in this case, it is an example related to children, as I am a pediatrician and think a lot about how we can do more of these types of models for children. So on the next slide, this is an example of combining financial and social incentives for COVID-19 vaccination. So I know Kevin Volpe at the top of the panel today talked about the incentive programs for COVID-19 vaccination, many of which were these large $1 million incentives. I served previously as the Chief Health Policy Officer for COVID-19 in the North Carolina Department of Health and Human Services. We also offered $1 million incentive program, as well as scholarship drawing for teams who were getting COVID-19 vaccines. We also had a separate program. These were small guaranteed financial incentives. And I wanted to give this as an example because we did an evaluation. We actually demonstrated that it did have an impact, and it actually had an equitable impact, which is another key theme I wanted to hit on today. There was an equitable impact for these particular nudges. So we started by offering $25 cash cards for COVID-19 vaccination. So again, guaranteed small financial incentives, both for either getting your first dose of your vaccine, so receiving that first dose at one of our participating vaccine sites, or the social incentive component of this, or getting a $25 gift card for transporting someone to get their vaccine. And we really were thinking about that social incentive part because we rolled this out in the summer when, I think Kevin made the point earlier, at that point, the people who had really been raring to get their vaccine, they had gotten vaccinated, even when we had demand that was far outstripping the supply of available vaccine. And really over the summer, we were at the point where we wanted to, number one, be able to make it easier for people to get vaccinated, because we had a lot of people in North Carolina, as across the country, for whom they had true cost and transportation barriers to access a vaccine. So these small guaranteed incentives were really designed to help address some of those barriers that we knew were really important to address for more equitable distribution of COVID-19 vaccine. And then the transport or social part of the incentive is, we also knew at this point that for many people who hadn't gotten vaccinated yet, they were really looking to be able to hear, get that nudge, have a conversation with someone that they know and trust, who might also be able to help bring them to the COVID-19 vaccine site. So if you could do one more click, please. We actually evaluated the pilot of this incentive program, which we ultimately did scale statewide. And in this table, what you can see is that in the pre-no incentive period, we looked at where we were offering these incentives compared to the rest of those counties and the rest of state. And then all the way over to the right, when we looked at how the rates of vaccination changed once we implemented these incentives, what we saw the impact being is that uptake vaccines fell by half without the incentive. And again, this was over the summer where across the country, vaccine rates were falling quite quickly. Where we offered these incentives, the rate only fell by 1/4. So it cut that rate of fall in half. In addition to this overall, what was the impact on vaccination rates? We had teams on the ground surveying individuals who had received one of these cash cards for getting vaccinated. And we saw that they were particularly important for individuals who were low income and who were Black or Latinx. And so, we were really pleased to see that this combination of a financial with the social incentive component design was able to both promote a lower decrease, a reduction in the fall rate of vaccination and more equity in the way that the vaccines were distributed. So just as thinking in the future, as we think about how we can leverage behavioral economics for a healthier future, thinking about designing more nudges that combine the financial and social incentive components. On the next slide, for the second theme I wanted to cover is thinking about cooperative incentives that really help promote more nudges towards addressing whole person health. And the example I'll give here is from our North Carolina Integrated Care for Kids model, which is a CMMI funded care delivery and payment pilot model to integrate care for children birth up to age 21 in 5 central North Carolina counties. And when we say integrated care and whole person health, we are really talking about, I say it's integrated care on steroids. It's not just physical and behavioral health. We're integrating with schools and early care and education and food and housing and juvenile justice and child welfare. So really thinking about the holistic needs of children. The area I wanted to highlight here is thinking about the incentives. And we have in this model both the authority and the mandate to implement an alternative payment model. Now, to the question that was asked earlier, what are the opportunities or are there examples where payers and health systems have worked together to design nudges? We, in this model, have been bringing together Medicaid, our MCOs, and our health system leadership every single month over the last 2 years to design this payment model together. And what we really looked at here when we were thinking about the payment model is what are the performance measures? Because I know that Kevin Volch showed earlier, we still aren't using a lot of incentives in value-based design in general. I will tell you for children and children's healthcare providers, it's even lower. There are not a lot of alternative payment models designed specifically for children. And so here we came together, payers, providers, to choose and align on, number one, what performance measures did we want to select, which were really going to help drive the incentives. And you can see in this table that the first several rows are really pretty novel measures when you think about the types of measures that we typically include in an alternative payment model or measure in healthcare. So this includes things like rates of kindergarten readiness and promoting kindergarten readiness from primary care settings, screening and addressing food insecurity and housing instability. We also included other healthcare utilization and cost metrics. And I'll just call out again with this focus on equity, one of our performance metrics we selected to really put a nudge on is centered around equity and looking not just at increasing the rates of well child visits for infants, but really the incentive is tied to specifically a reduction in the disparity for infant well child visits. And not only did the health systems and the payers coordinate on selecting these metrics, we are actually doing this in a what we call pooled performance measure by provider approach, meaning that the payers have agreed to come together and work together and assess the performance of health systems across all of their children, regardless of which plan they're in. So this is, I think, a really nice example, number one, of as we're thinking towards the future, thinking about how can we actually support and financially sustain strategies that address whole person health. And number two, a nice example of actually systems and payers coming together to design these types of nudges.
Charlene, thank you. That was just simply terrific. Carl, Ron?
Thank you. I didn't prepare any slides specifically for this because I really wanted to try to build on where the conversation was going. My main thought on this is that while we're concerned about behavior change of an individual, the problems that we actually face are mass problems. We have to change 100 million people's habits. And so there is a risk that I'm an engineer by background is that the scale of the solution has to match the scale of the problem. And we basically have a mass market problem that is composed of individuals. But what I'd like to do is kind of back up then to some of the pieces that Cass was describing, because they really provide some principles about how to think about creating the collective change that we need to do, which is to change 100 million people's habits on every one of our chronic disease problem areas. And so the way we would normally do that, thinking about a mass market approach, is to understand that mass market change is also behavior change. But the techniques that are used are slightly different, because the goal is to move very, very large groups of people. So the first thing is I would say we turn all of those kinds of behavioral problems that were discussed in the biases into a situation where you name 4 segments of consumers or patients, if you will, whose habits you want to change. And it actually, there are simple ways to be able to describe those 4 segments, and I'll just leave that aside. But by doing that, what you do is you recognize you're going to move 4 different types of people. One of the problems when you look at a market is if you don't define some very large groups to move, you get lost in the minutia of the differences between the people. And so to create a mass market, we name 4 segments and we make sure it covers 100% of the population, so we're not leaving people out on the side. The second problem, though, then, and this was really characterized by the discussion of fee-for-service to value-based care, is that we need to set a 10-year goal then of where do we want that market to be in 10 years, and then work backwards from that goal. And so we set a very specific goal, but then we can assess how many people are already into that goal. Well, with 25% of people doing some combination of fee-for-service and value, we're in a diffusion model of what's called the early majority. And so there's early adopters, early majority, late majority, and laggards. And so the appropriate incentives are for where the market is in its development. And so right now, the barriers that we're trying to remove are the barriers to moving from early majority into later majority. And so those types of things are exactly the kind of situation that made it very relevant when it was discussed about the different incentive structures that are used. And so strong incentives are actually used in the late majority time, not in the early majority time. And so when you start thinking about a mass market movement as name your 4 groups of people and name where are we in time, that defines the space that we're going to try to collectively move to become a new mass market 10 years from now. And so what really creates problems is if you use the wrong tools at the wrong time. And so what you saw is some of those kinds of incentives that were used that are weak incentives, they're just the wrong time to use them. It's not that they don't work, but it's the wrong point in time to put those incentives in. As we get to something like vaccination rates that are now 60% or higher, of course, it's the right time then traditionally to start using strong incentives at some level because the market's ready for them. And so the thought that I have first and foremost is this type of an group of people is a collaborative group that could come together to name what is the goal we want to have 10 years from now, and then all get onto a common action plan, which names, so how are we going to agree to segment the market? We're trying to help people, but put all 100% of the people into those 4 groups, and then recognize where we're on time, and then we start getting a coordinated action of using those incentives to move. A last comment on that is that what that typically looks like is you pick one segment first, and you address the early adopters there and their needs, and then you move that first segment into the early majority behavior with the right incentives, and then you move them towards the late majority. But when that first segment is well developed into the early majority, you're ready to now start talking to the second segment and get them through to early majority. And as they progress forward, now you're ready to pick up the third segment, et cetera. And so what we're doing is we're taking a coordinated movement to create essentially really a movement, not a business plan or something, but a movement. And so I'll make one last comment about that, because it was really in Brent's conversation about autonomy and professional values. Well, the people that we're serving also operate on the equivalent kinds of things of professional values. They want autonomy, mastery, and purpose. But we'll have to fill in for some of the mastery that they don't have. But when we're creating a movement, those have an equivalent of recognizing that the way you create a movement is you have to give something to somebody that they accept. Then they have to have permission to change it, to customize it themselves, and only then will they extend it to others. And so the dynamics of creating a movement are to put the right things in front of those people and then do that kind of, to use the language of nudge, but to recognize that when you get an acceptance and a change, then you get an extension. And so that creates the movement over the 10 years. And so let me just stop there, but my thought is to put the dynamics of thinking about how mass markets are created on top of our discussion, because that really is behavior change. It's just done in extremely large groups of people.
Thanks, Carl. I mean, it's just a really creative way of thinking about mass markets and consumers and applying it to healthcare. That was great. Anyase?
Thank you. So pleasure to be here. So give my small segment of this talk. And I just want to say that I focused, you can advance the slide, I focused on the healthcare provider sector, which is obviously important, but I just want to call out there's a prevailing, equally important patient-facing sort of contribution to health system transformation that I've not addressed, but I think we should be very mindful of. So to level set sort of health system transformation, I define as realignment of the prevailing structures, processes, and culture in clinical practice towards high-value care. Now, you can decompose high-value care in several dimensions, but for me, sort of I index on equity, effectiveness, and efficiency. And at its core, though, health system transformation really implies modifying human behavior. And I think we're in the midst of that right now with the natural experiment of the evolving COVID-19 experiment, and specifically how within the healthcare context, how we socialize, deliver services, and actually work have been reimagined. But with great humility, I also sort of offer that where we are right now in the trajectory is that we're now beginning to say, okay, will these behaviors stick? And I think if you look at the telemedicine adoption rates, there is now some atrophy or some regression, not quite to the level of 2019, but certainly we've lost a fair bit of that momentum from May, June 2020. So I think what this phenomena points out is that for durable transformation involves two things. One is that we need to break with old habits, but fundamentally, transformation requires a new state of resilience, either at the human level or the organizational level. Next slide, please. So I actually leverage a heuristic, which is called the serial order heuristic, by putting my take-home slide up front. So this is probably the take-home slide for my talk today. And when I think about behavior first health system transformation, there are really four main themes I want to hit. So the first is it should really map towards why. I think the charge for health system leaders is to sort of articulate a mission-focused why for health system transformation. And this does two things. One is, most importantly, it creates organizational cohesion as to why we're pursuing health system transformation. And what that does is it then makes the goals of transformation actually shared by everyone, which sets up the second point, which is it creates buy-in legitimacy for this health system transformation. Secondly, and this is obviously the point that Brent James laid out beautifully, we have to tap into what really motivates employees, and I'll not sort of rehash what Brent said, but I do believe that sort of healthcare is fundamentally a mission-focused sort of construct with a social contract. I think that's why intrinsic motivators, incentives, sort of far outweigh from an impact standpoint and a durability standpoint, extrinsic financial sort of incentives. And others have talked about this, Kevin, Mitesh, and Cass, but like this idea of designing environments with behavioral economic principles in mind. And I'll reframe it a different way. So we should design the choice architecture and minimize friction or sludge in the healthcare setting. So we now encourage or empower behaviors that map towards healthcare transformation. And lastly, I think that data and transparency could be major enablers of health system transformation. Data, either upstream, because it sort of guides our decisions, as to where we should transform. And B, downstream, it sort of validates a particular course of action or certainly invites amendment or course correction. Transparency, because sort of in my work here at MD Anderson, we've observed that actually transparency on outcomes could be a massive sort of like has a massive momentum building or compounding effect in health system transformation. So very, very critical. Next slide. And so Deloitte sort of put out 2 frameworks for health system transformation in the organizational setting. They actually focused on government, but I actually loved it, and I sort of referenced them here. One is sort of thinking through identifying, understanding the drivers of behavior change, and then sort of design interventions to change behavior. Somewhat intuitive, but I like the phased approach. It doesn't have to be sequential, it could be in parallel, but at least sort of vectoring to each of these buckets, I think is critical as we think about sort of health system transformation. Next slide. And they also sort of thought about sort of when you think about what are the drivers of behavior, they had another framework that they called FIRST, so that's fundamentals. And this gets to the heuristics and psychological factors contributing to human behavior. Incentives, as has been touched on already. Relationships and stories. I think these 2 are critical, one, because they map towards why, but also at its core, we are humans and humans are social animals. So relationships sort of creates by way of normative invocation, what is acceptable behavior. So you can leverage that towards healthcare transformation. And stories create resonance around mission, values, and narratives. And that's, again, that gets to why I think that creates stickiness around healthcare transformation. And lastly, we talked about this a little bit in several sessions already, but sort of thinking about the tools. And I'll say, as we design these tools or the environment for healthcare transformation, there's a strong proposition to be made, value prop to be made for actually leveraging human-centered design, designing these tools, right? So taking the human perspective of employees, patients, as they begin to bake in these behavioral economic sort of like instruments in healthcare transformation. Next slide, please. And this slide just touches on another point I made about sort of why for healthcare, given the mission focus, the social constructs, and all the other reasons that Brent laid out, sort of intrinsic factors sort of by far and away are the more compelling sort of instrument than extrinsic factors. First of all, they're cheaper actually, and they're scalable. But this paper at McKinsey sort of laid out why sort of healthcare organizations significantly outperform other sort of complex organizational constructs with the effectiveness or stickiness of intrinsic factors. And this sort of lays it out there. Next slide, please. And this is sort of my second to last slide. And I just sort of want to call out that, health systems are highly complex, very interrelated. So healthcare transformation sort of will never be a one and done undertaking. And we need a structured process for thinking through sustainment and course correction as appropriate. And next slide, and this leads into this whole field of implementation science. So for those who are not familiar with this, implementation science is basically the formalized study of the factors that contribute to adoption, sustainment, and success of evidence practice in clinical care. However, we can leverage this framework for health system transformation and in many ways sort of build our transformation muscle at the organizational level. And also, I think implementation science allows us to embed equity. So when we look at these causal factors of structural, organization, patient, provider, innovation, it allows us to rethink sort of respect to the receipt, access to, and outcomes of these health transformation efforts along racial lines, LGBTQ lines, age lines, cultural lines. We can sort of uncouple, break it down by those lines using this framework and making course correction as necessary. This is my last slide, and thank you so much.
Thanks, Anyaze. That really tied together several of the principles that we've been hearing, put the threads together nicely. Thank you. Session?
Good afternoon or good morning, depending on where you are. Really an honor to be here and to have close to the final word here. So, I bring with me the perspective of having led a large provider group in the form of CareMore, as well as now presently leading Scan Group and Health Plan, which is an organization that's focused on keeping seniors healthy and independent. And I just want to kind of bring to bear the health plan perspective on this issue. When I think about, at a macro level, what it is to actually lead a health plan, it's actually leading a very large behavioral economics exercise at scale. The very act of designing health benefits, what we cover, how we cover it, is in fact an exercise in behavioral economics. And we are, I think, sending signals to patients ultimately about what we value and what behaviors are actually desired through our coverage determinations and our coverage decisions, whether we treat it as such or not. And so I think, there are the very specific experiments that have been talked about that I think have demonstrated, I think some really, incredible outcomes. But I think it's important for us to take a broader look at this issue, which is, we are literally designing, people's healthcare journeys and experiences when we design their health benefits. And we are sending, I think, a number of different signals. When I think about the unintended consequences of, running a health plan and setting benefits, I think about the notion of trust and how our design of benefits can be both trust enhancing as well as trust eroding. And what I mean by that is, when we make primary care visits, $0 copays, what we're saying implicitly to patients is that we want them to seek primary care. We're eager for them to seek primary care. But when we do things like add copays for insulin, which makes absolutely no sense, we potentially erode our trust with patients. And I don't necessarily know that the managed care industry has necessarily taken this notion of trust erosion as seriously as we can and as we should, because while we are trying to manage total cost of care, some of the ways in which we do it ultimately erode trust. So what I'd like to just add to this conversation is this lens of trust and this notion that we as an industry, managed care, but healthcare more broadly, have an obligation, I think, to view exercises to manage behavior or nudge behaviors through the lens of whether they actually increase or decrease trust in healthcare and decrease trust in the healthcare system. This is obviously, a very important topic in the midst of COVID, as well as, some of the issues that we face right now around, vaccination rates. And so I would just ask us to take this broader lens and think about, how we as an industry can use behavioral economics to enhance trust and also guard against, the potential erosion of trust that follows when we don't necessarily view interventions through the lens of whether we're actually building or eroding trust in communities. So I'll pause there, and I know the panel will probably have a very rich dialogue at this point. Thank you so much.
Thanks, Station. I hear people say periodically, what is our number one problem that we have to solve? And not infrequently, it's getting over the trust issue that's been developing in the last time. There are a couple of questions that came in. One is talking about the complexity and as the background, and interesting to consider how pervasive sludge and inertia are in healthcare, manifested in administrative ways, low value care, clinical variability where strong evidence exists, and how this has been allowed to proliferate, especially in the view of Brent's comments about the essential roles of autonomy, mastery, and purpose for clinicians. So the drivers are manifold as well, including risk-averse nature of healthcare, fragmentation and complexity in both care and coverage. So what do we think is the way out of the quagmire by culture change, policy change, payment reform? What will it take for facilities to place a premium on sludge busting? Let me look to Carl.
The principle for adoption is anything you want to do has to be simple or it'll never be adopted. And so I almost wonder whether, so I actually love the concept of sludge just because nudges become so popular, okay, that, you get so many nudges that you get pokes, okay, and they're really sludge too, okay, whatever you. And so much of what we do is really complicated, and it needs to be simple as a first rule. And so I think that's the real issue, is if you see something that's hard, it has to be attacked.
So it gets back to the principle that folks were talking about in simplicity that we've heard over and over again today. Others?
Jim, I might add to that. I think, part of what we've learned as we've been trying to do this cooperative co-designing work around whole person health, where it's hard. The things that we're asking the different stakeholders to do is hard. There is some lift involved. Is I think having that co-design process with the various stakeholders at the table is really important, because in the design process itself, the different perspectives can be represented to say, hey, that sounds like a great idea. Let me tell you what that would mean for me as a primary care provider, and how that would introduce an immense amount of sludge into what I do in my day-to-day work. And so that you can think about as much of that on the front end for the different people who are going to have to be doing the doing as we design these different interventions to try to promote health and healthy behaviors.
Jim, can I make a point? And just want to mention that I think sort of no one intervention, policy, behavioral economics by itself will like really move the needle. I think of this as almost like a mosaic, so sort of a bit of everything. I think the trick or the art with this is sort of right sizing to a given clinical context, which blend and what volume of a specific like sort of element makes the most sense, right? So I think if with great humility, if we all think that behavioral economics will design us out of where we are, I think that's probably not going to happen. But I think sort of it's just thinking about this at the mosaic and saying, okay, how do we sort of tailor to a particular situation which incentives really move the needle? I think that's probably the art of leadership on the front lines for this.
So a systems engineering problem that requires this mosaic kind of view.
I mean, only because healthcare is just so complicated with emergent features that I think sort of we need to really tackle it in a complex system-based manner.
Another question that came in had to do with all the opportunities to change things in items that we're familiar with that should be easily changed. Use of generics over imaging, this sort of thing. And when first encountered, many providers and administrators probably recognize these things don't make sense, but once they get habituated in the system, they tend to be ignored. Is there a systematic way in recognizing them and proactively using an M&M kind of approach or some such thing to apply logic to this upfront in an institution? Sachin?
Yeah, I mean, I would say, I think one of the biggest challenges we have, when you're leading an organization is implementation bandwidth. You can only do so much at one time, and you can only ask people to accept so much change, at one time. And, one of the problems that you have in large, complex organizations is you have lots of groups of people who believe that what they're doing is literally the most important thing. I'm sure you've never seen that at all, Jim, in your career. And so, this idea that, we're going to be trying to simultaneously move site of care, increase generic prescribing, and change incentives for clinicians as well as patients all at the same time is overwhelming for folks. And, I think so much of what we have from a burnout perspective and an erosion of trust perspective is the fact that we are not thinking end to end and we're not being super complete in our approach. And we start new things before we finish other things. And rather than being comfortable with the idea that we're going to just, set our sights on a specific set of goals for now, complete it, and then move on to the next thing. And so I think, I've come to view leadership as probably the most important missing ingredient to implementing any of, change initiative within organizations. The design is simple. What I think is most complicated is actually, moving, people and organizations to do the right thing and feel good about it at the same time. I think that is the most challenging piece.
May I build on that?
Please.
I think that I think this question of leadership is very important in this place. And what's unusual about the healthcare market and the complexity is its sheer size. We just aren't dealing with 3 trillion plus markets in most cases. And as a result, anybody who has a $100 billion business has a nothing market share of this market. And so as a result, yet you can't change them because they're $100 billion business, and so it really asks us to step up. And that's why my comment about this type of a collaborative where everybody's present is really important, because we really don't have a leadership vision, a shared vision of where we want to be in 10 years or in however many years you want it to be. And so we're not working on the same thing. And I like this point of view, which is you basically have to chunk off what are the 5-10 barriers to that vision, and then you build a plan for each one of those 10 and you work on them and you move forward by removing barriers to the future. But if we haven't articulated the vision and we don't have that, this is to follow Cotter on why transformation fails. You have to have a vision and you have to have a guiding coalition, and then you have to have early wins. And so there's a real opportunity for us to come together and determine, what that roadmap is.
And Carl, the reason you're pointing out the guiding vision and a coalition is because we have guiding visions now. We just have 1,000 of them.
You're right. Which, we don't have visions. Okay, we have delusions if we have a lot of visions. And so a vision would be shared, and shared and communicated. And we don't have a shared vision and a shared communication. And that doesn't mean that we don't have conflict and differences and whatever, but we come together at the level where we can find that commonality, and it becomes the vision. And that's what we share. And that's what the coalition can deliver, if you will. But right now there's too many. And so on a bad day, I like to point out that the quadruple aim is marvelous, except it's an agreement to disagree.
The one message that we heard all day today, starting with Cass and Kevin, and just went through to everyone, touched on it, is the how important simplicity is. And yet I think it would be easily argued that in the last 25 years, year by year, as we try to achieve a better healthcare system, we've increased the complexity almost year by year. How do folks think we start dealing with that?
So Jim, I kind of want to, I'll sort of answer that by circling back to Sachin's point about limited bandwidth and limited resources as well. I think sort of one way to approach to a question prompt is just to be very disciplined and data driven, right? So we can all agree that sort of when I die, hopefully in about 50 years from now, healthcare will still have problems, right? And that's sort of the appeal of this, actually, this space is sort of, there'll still be work to be done. However, incremental change is not insignificant change in this regard. So then how do we move forward meaningfully? I think we have data drive that. So we have data inform where we choose to play with respect to clinical transformation, leveraging behavioral economics. And the criteria could be volume, could be dollars, could be impact, could be equity. But I think that's how you sort of break this nut and simplify it by being disciplined in where you direct activities based on data.
Yeah, and I'll add to that. I think, the discipline in being brutal in our prioritization of what we're doing, and then very clear in the communication about what it is we're doing and why and how this is going to benefit which people, and certainly we always think about our patients, but, to the point, Sachin, that you were making about the burnout and the teams, particularly after the pandemic, so tired, right? We also need to make that value proposition to the teams who are doing this work, both within healthcare. Then let me put one more plug in, also our partners outside of healthcare who really need to be engaged and are hurting in many ways much more than our healthcare system is right now. Our partners who address things like food and housing and our educational system for children. So I think prioritization, using data, and making sure we're really clear about our communication and the value proposition for the various stakeholder partners.
I would like to pull in others that participated in this conversation earlier. Kevin, Brett, Mitesh, Nancy Ann, others that presented. Then now that they've gone through the entire set of presentations, do you have ideas that you'd like to expand on a bit? And someone who is always up for that is Brett, so I'll start with him.
It's interesting, Jim. If I were to name the one thing I think that could make life better, it's to redesign our EMR systems along a clinical line. It comes from, I really like that term. I hadn't heard it before, the idea of sludge in the system. I think that a well-designed EMR system could go an awful long way to reducing complexity on the front line. It's a key tool for deploying clinical decision support. You may have noticed that most of the good examples we had of nudges, effective nudges, were based on an EMR. What we have, of course, is a system, we all know this already, but just to state it, we have EMR systems that are primarily designed for fee-for-service billing. And then they kind of do clinical decision support as an afterthought. What if we flip that metric? What if we designed for the clinical environment and then we did the finances as a secondary? This is one of those things that's so pervasive across everything we do. And I think it would give us a framework where these wonderful ideas, this has been a great meeting for me. Holy cow, I've learned a lot. I just want to get a good summary of it so I can hold on to it. But it's one of those things where the ideas that we've been hearing today, I think it would facilitate all of them. So that's just one thought.
Well, let me probe that thought a bit. Do you think the EMR should be a digital tool that we use, or it should be, as it currently is, the digital tool that we use?
So Jim, I spent a lifetime building clinical decision support into clinical workflows. I wish I'd had this wonderful theory that I've heard here today. It would have made me dramatically more effective. We were kind of stumbling along, feeling our way. I jokingly say I can usually show you 5 or 6 ways not to do something because I think we stepped in every hole possible. Just failed towards success. My eventual conclusion was, though, I think properly designed, it will be a suite of tools. Now, here's the trick, Jim. I've seen examples of what it can be. And they are dramatic shifts. So I realize that it's clearly in the realm of the doable. If you see what I mean, this is within our reach. It would be a massive shift, though, a truly massive shift. So on the other hand, this has been such a productive conversation. I really don't want to steer us away from the content of this conversation off into Never Never Land over here where I'm going. So.
Right. Let me ask Kevin to update his thinking after hearing all these presentations that followed his second one today. Kevin?
Sure. Well, I think there are a few key themes that I heard coming up over and over again. One is the need for more simplicity. I think a lot of us probably see that as an antidote to sludge and the increasing complexity of systems, which just seems to happen by itself over time. And it's interesting that nominally the theme for this whole session is about incentives, and I think we can think about various forms of choice architecture and defaults. While Cass describes them as not incentives, they're not financial incentives, but they're certainly ways to steer people towards doing things that are easier for them, that align with what they want to actually achieve. And I do think, that said, we have to recognize that since doctors are never going to work for free, there's always going to be a payment system, and that payment system has embedded incentives. And so we might not like that. I love the notion that, Brett, that you highlighted, that if we pay people enough, they're not going to be worried about money and thinking about it as much. And I think that's probably true. But of course, however we pay them, there are going to be incentive effects. And I think we need to be very deliberate in recognizing what those are and making sure those align with the organizational goals, whatever they might be.
Thanks. You know, I was, as you were saying that, I was thinking of a study we did in collaboration with Rand Health a few years ago that looked at, you know, incentives and disincentives from physician point of view. And there was a lot less attention on finance than one would have guessed. It was really all about the experience with the patient, the time with the patient. And that and some subsequent work makes one wonder whether the financial aspects of sticks and incentives, when it gets down to the provider, are actually disincentives in a way. And, you know, Brent sort of in an angular way touched on that in his presentation. Another question that came in for the group, what role do different stakeholders, boards of trustees, community-based organizations have in nudging impact and supporting implementation? And I know Charlene touched on in her presentation, you know, sort of the wider view of stakeholders. Charlene, do you want to say something about that?
Yeah, I just think it's so important, you know, again, as we think about what are the things that are actually impacting the health of the patients that we're seeing in our health systems. So much of it is happening, the majority of it is happening outside of our 4 clinic walls or hospital walls. And so I think there is a real imperative, and the data only gets stronger every day, that there's a real imperative to think beyond our walls and really thinking about how we can, from a financial standpoint, since Jim, that's the topic of the day, these incentives, right? From a financial standpoint, what are the ways that we can share these incentives, do blended and braided funding to really help sustain and bring some of these really important community partners to the table. And then I think, Carl, to your point earlier, right, when we're talking about that shared vision that we need to have, it needs to be a shared vision truly if we're going to achieve whole person health and well-being. That is a shared vision for healthcare, our payers, and our partners outside of healthcare.
Other comments?
Maybe just one more on following on that is I think that it's important to understand that when we want to make these changes, that I'll just say all human decision making is Bayesian, and so it's very important to understand what's the context and then what are the priors, and then people do risk management. And so it's a 3-step process that people go through it. And the problem is when we don't all agree the context, what is the narrow thing we're trying to do, and then do not. And this is similar to one of the other models, you know, that was being discussed is if we then don't understand the context first and then figure out where people's priors are. Okay, in other words, and this is what my comment about the segmentation, for example, is they're coming from different places. And then we ask them to do something. Well, it won't work if we haven't agreed those 2 first steps, because they themselves, the patient actually, or the doctor who's making a choice, they do risk management. That's their activity. And then they go back, and that might change their priors, and they do it over and over and over again. And so behavior change is iterative. It's not performative. And I don't think we're conscious enough about making these specific choices about, so what change are we talking about making? And then finding out where are all these different people. And the reason this comes to mind is because the boards and all these other people, they're coming from very different places too. And so they're not going to act together unless we find a way to get clear on context, clear on priors. And then they themselves, the person who has to take the action, does the risk management. We don't do it for them.
Jim, can I make one point is, as you think about bringing in multiple stakeholders, it certainly sort of escalates the impact for sure. But I do think to pull it off, the complexity also goes way up. And sort of to get alignment across boards, across caregivers, across patients, across community health workers, across health system employees, very tough nut to crack. And one way could be to tailor messaging to each stakeholder in a way that resonates with him or her. But I just want to call out that that is the goal, but it is fairly difficult to pull off.
Well, let me just move to some closing remarks. It's late in the day and people have been doing the most unhealthy thing of all, sitting for 3 hours. So sorry about that. But, you know, I think a couple of things that we've heard that have just been amplified, you know, is to keep things as simple as possible. And yet we're in a healthcare realm that continues to increase in its complexity and moves away from simple. I remember when asked, when Cass was asked of these behavioral dynamics, which do you apply to different domains, you know, provider, patient, healthcare system, his response was, don't think of them as domains, but think of just defining what the problem is first, and then what can be applied to that problem. And that sort of reflects the suggestion that Carl Ron made of, you know, what is the 10-year vision, and, you know, what primarily are the barriers that could be spoken of. Brent called out one potential barrier that I think a number of people might agree with or might not, but that would have to be discussed. I certainly do. And Yaze mentioned that this too has to be simple, multiple stakeholders. You know, how do we get through that complexity and make that reasonably simple? I think there was it resonated with everyone that that the pink separation of algorithmic and heuristic processes, and the recognition that you know, institutions, healthcare institutions at the top may be somewhat algorithmic, and that may be why they can respond at the top to financial incentives. But once one gets down to where the action is with providers and patients, it's all heuristic. And so how does one even think about the transition of incentives down that waterfall of systems that are built very differently and have very different dynamics? The other aspect that was brought out is how going to intrinsic motivators, intrinsic incentives in this system is probably always going to trump the extrinsic incentives. And yet, you know, the extrinsic incentives are currently highly relied on. And there's a relative lack of intrinsic incentives. You know, once you get down that water cascade from the top of an institution to where care takes place. There is a comment about, you know, establishing, could multiple stakeholders even agree on a 10-year vision? That might take a piece of work, but might be worthwhile doing. So some of my take home from this, and with that, let me pass it to Diane for her observations.
So thanks, Jim. Yeah, I mean, I agree. I think what's been surfaced is the juxtaposition of the complexity of the world that we have in terms of the delivery models, the payment models, all the different kinds of subpopulations and different drivers that we see, and then the kinds of things that people say would actually be helpful. So how do we think about simplicity? How do we think about starting with a problem? I'm looking at, you know, kind of the world of a payer-provider integration every day, and thinking about the fact that we have to make very often rapid decisions because we're all staying in business every year, whether we're clinical delivery systems or we're payers or we're whatever we are, right? We're working toward our goals and objectives. At the same time, seeing that things are not going for patient care the way we'd like to see it. And so I thought there was great richness in this conversation today, and it has given me a lot to think about. But I think I am struck by the fact that there is no design that's clear. And I don't know how hard it would be. I think it would be hard for us to actually get agreement on what is that end goal once you get beyond the high level. I think you'd have a fair amount of agreement at the high level. And I think then you'd have a lot of opportunity for hard work trying to execute on what actually would create that opportunity to deliver on those goals. So, but I think this was a wonderful conversation today.
Well, thanks, Diane. Michael, do you want to close?
Yeah, and thank you very much, Jim and Diane and all. I will make a few summary comments that I jotted down as I was listening to the discussion, which was, as everyone has said, just fabulous. I think all of us, I don't know if there'd be any exceptions, learned a lot in the course of the conversation. The items that I jotted down, the 6 of them really related to the choice architecture priorities and decision filters that people teed up. And I'm sure there are probably 60 others that have been identified by folks in the audience and on the panels. First was reducing sludge is half the battle. Leadership is the other half. Second was, in effect, assume the best motivations. Brent pointed out the importance of autonomy, mastery, purpose as trump notions in terms of human intention. The third was, we heard so many times, keep it simple. Whether it's through the tool of the EMR, the notion of opt-out, opt-in. Clearly, opt-out is easier than opt-in, despite the fact that there are some circumstances in which that's difficult. The fact is that we should do what we can to keep it simple. The fourth was, and this is instinctive to us, but I think the explicit calling out is critical, and that is that time matters to everyone. The 4-letter word is not just life, it's what it's the unit of measurement of life. Time matters, and we need to be more respectful in everything we do and to think about how we can ensure its maximization for all involved. The fifth was, this wasn't a soundbite like the others, but it essentially was an overarching theme, and that is align payments with the whole person, whole organization, whole population, and use that as a key architecture priority. And the sixth on this list that I jotted down was enhance trust consciously. Think about things that enhance trust. If we're trying to build a set of priorities and procedures and perspectives that will take advantage of what we're learning from behavioral economics, we can do a lot better with some of these simple notions. Brent underscored his interest in a good summary. I certainly want a good summary. So and I think there are a lot of things that we can build on and will build on in our work across the board in the National Academy of Medicine and the Leadership Consortium. On that count, I should mention, looping back on the vision notion that Carl has underscored. In the Leadership Consortium, with the focus on the learning health system, we've been building on the core principles that were identified in Crossing the Quality Chasm and expanding them in an updated fashion with focus on transparency, on issues related to the importance of data stewardship. And it strikes me in listening that even though the 10 principles we have now under the Learning Health System rubric, it don't represent individually a vision. They certainly represent collectively a vision that can be guideposts, nudges, sludge busters, if you will, in a variety of sectors. So we'll continue to work on that with you and for you, and we'll share them with all of the participants today to solicit your input and suggestions, as we will also encourage you to send any suggestions along that came to mind in the course of your participation today, whether you were on the panel or in the audience. Let me underscore our thanks to the keynote speakers, each of the panelists, for bringing your tremendous intelligence and insights to the discussion, offering us a very important set of reference points to move forward with. Thanks to the staff who put this together. And let me just mention a few names. I'm going to mention Mike Cocciola first, because his name hasn't been mentioned yet, but he has a research associate who took on this session with a passion. I think Jimmy was channeling you at every step of the way. And Allison Lester, who you've heard reference to as really managing the logistics moment to moment. Jennifer Lee, our visiting scholar, Ayatollah Anisha, Deputy Director of the Leadership Consortium, Olivia Matungo, who was a program officer involved formerly. Thanks to, heartfelt thanks to each of you who've done such a good job in organizing and implementing today's meeting. And of course, finally, well, not quite finally, but certainly foremost in some ways, thanks to our two chairs, Diane and Jim, for skilled stewardship of the conversation. The final thanks I'll give to each of you in the audience who have tuned in and are providing leadership in your own home venues. And please share with us any thoughts you have about ways in which we in the Academy and as a field can advance progress. So thanks to all of you. Everyone stay safe, be well, and have a wonderful holiday season. Take care.
Michael.